Okay, good evening, ladies and gentlemen. This will be the last evening of gynecology. So we had 4 evenings of OB and now 4 evenings of gynecology. And this is where we left off yesterday, suggesting that there is a lot of differences between men and women in terms of sexuality. I like some of these. They, I think, express it perhaps pretty accurately. Men are like light switches. Just flip them on and they're ready to go. Women are like irons. Just a minute here to make it my... Okay. Women are like irons. Plug them in and let them warm up. Or wait, is it that men are like microwaves? Push a button to turn them on, and women are like crock pots. Need to simmer. Beautiful woman looks in the mirror, and what does she say? Oh, I'm too big here. I'm too small there. How about a man? What does he do? Doesn't matter what he looks like. He thinks he's a big, perfect stud. Okay, let's look at the human sexual response from the standpoint of the innervation. It is the sympathetic nervous system, which is responsible for orgasm. These are tonic-clonic contractions of the pubococcygeus muscle. There is more variability in women than men. In men, it's no question, did he have an orgasm? If he didn't, nothing happened. But for many women, it may be just a pleasant experience and not the lights and the flashes and the fireworks. For women, they are capable of multiple orgasms, whereas men have to have an obligatory refractory period. So the system control, it is a return of the physiologic functions, the pulse, the blood pressure, the galvanic skin response, back to baseline. In men, it is faster, and in women, it is slower. When a man has had an orgasm, what do you hear about 20 seconds later? Snorgasm. That's not the time to go to sleep. That's the time to say, honey, you are so important to me. Okay, the refractory phase. This is the inability to repeat orgasm until a given period of time is gone. This occurs only in males and varies with age. With a younger man, it'll be shorter. With an older, more mature gentleman, it could be a few days, maybe even a few weeks. 15% of women don't have orgasms compared to 2% of men, which is quite significant. 15% of women have primary anorgasmia, and we'll talk about that coming up in just a little bit. It takes the average woman 12 minutes to reach orgasm compared to 2.5 minutes for the average male. So there's a lot of gender-based differences. The parasympathetic nervous system is for the engorgement. The sympathetic nervous system is for orgasm. P for parasympathetic and point, S for sympathetic, and shoot. All right, let's look at the circular sexual response cycle in women. The circular variable stage relationship in female sexual functioning, emotional intimacy and relational satisfaction is far more important to women than to men. Female sexual functioning is much more complex. In men, it's much more simple. The goal of sexual activity for women is not necessarily orgasm. So let's look at the handout which I've given you. We start out, and for many women, their motivation, their incentive to participate in sexual activity is not an orgasm, but it is emotional intimacy. That is what motivates the sexually neutral woman to seek out and be receptive to sexual stimuli from her partner or otherwise. Now, there are biological factors, psychological factors that can impinge on this. If a woman has been sexually assaulted or raped, if there's been abuse in the past, that's going to inhibit in a negative way. But it is the sexual stimuli which then lead to sexual arousal. Sexual arousal leads to sexual desire, and that leads to more emotional intimacy. What is missing in this circular model? Orgasm is missing. It is not as essential for many women as it is for men. So this is something which you're going to see much more in the literature. This is looking at it just from a little different standpoint, but this is Rosemary Basson from University of British Columbia, a psychiatrist who in 2001 first talked about this alternative female model with emphasis on relationships. Okay, sexual history questions. Do patients want you to talk about sex? And the answer is yes. Now, many times we feel uncomfortable and we will express and communicate that discomfort both verbally and non-verbally. And patients will pick that up and will say, I'm not going to mention anything because the doctor is uncomfortable. And yet patients do want us to ask. In your notes, it talks about what are the sexual history questions. Is she currently sexually active? If not now, has she been in the past? Is her relationship with men or women or both? Don't assume it is heterosexual. Is it related with intercourse? If all of these questions are okay, relationship is satisfying, no difficulty lubricating, no pain with intercourse, that will cover 95% of female sexual concerns. In terms of previous history, age at first intercourse, the number of lifetime and current sexual partners, that's going to impact upon HIV risk and STDs. Is there a history of sexual abuse or rape? And statistically, I'll show you, it's probably around 15 to 20 or even 25% of women have been either sexually abused or raped. That's a huge number. Sexual dysfunctions. When you look at the prevalence of sexual dysfunction, this is probably the best study which has been done. It was 1,000 men and women ages 18 to 59 done in Chicago. And these were face-to-face interviews. 43% of women and 31% of men have had a sexual dysfunction in the previous 3 to 6 months. I mean, that sounds like an epidemic to me. What is the most common female sexual dysfunction? You should know this for the exam. It is low sexual desire. Arousal disorder, 14%. Pain, 7%. But it is low sexual desire. And that can be a problem when there's a discordance of libido between the two partners. Now, in men, the most common sexual dysfunction is premature ejaculation. Low desire is way down over here. So I would know that for the exam. Okay, when we look at sexual dysfunction, we can look at desire, excitement, anorgasmia, dyspareunia, and vaginismus. And I've given this to you, I think, on a handout. Or did I? Let's see, did I give that to you? Yeah, it should be coming up here. Anyway, let's go back and look at this. When you look at patients who are on SSRIs, which have association with decreased libido, if you don't say anything, only 14% of patients will ask the doctor about it. But if the doctor inquires, is there a problem? 55%. So ask the patients, don't just wait. In terms of excitement disorders, that has to do with engorgement and lubrication. There's a lot of alternatives for that. Here is KY warming jelly. Here's Astroglide, all different kinds of things that you can get. So that is highly treatable. Anorgasmia, 15% of women have never had an orgasm. And there's a lot of things which are available. And these are vibrators, which a partner can help her, or she can show what feels good with her. Dyspareunia is pain with intercourse. Since pain with intercourse may arise from both psychological or physical causes, a thorough history and physical exam is essential. We've talked a lot about different things that could cause this: vulvar lesions, vaginal infections, PID, endometriosis, a lot of potential diagnoses which can be assessed. Now, vaginismus is interesting. It is the only sexual dysfunction which is not diagnosed from history. You can do this on physical exam. And this is a patient who cannot let her legs go apart because she's concerned about pain. It's adductor contraction, and it is involuntary. If she can learn to place in her vagina narrow vaginal dilators like this and gradually work her way up, this can be treated very successfully. Vaginismus. Okay, here's the handout. Desire disorders, excitement, anorgasmia, pain with intercourse, and vaginismus. Desire disorders. This is from libido. If there is low testosterone because her ovaries are taken out, if she has SSRIs, we talked about that. Estrogen and progestin contraceptives can sometimes suppress the LH. The LH is what stimulates the Theta cells to produce androgen. In some women, estrogen progestin contraception can lead to decreased desire. These are fairly easily treated. But partner problems, if she has a jerk for a partner and she has no interest, that's why it's only 50% success. Because unless both partners recognize that they need to go for counseling, it's not going to happen. The excitement disorders, decreased estrogen, lubrication, there's lots of things which are available, and I showed you that 80% success rate. Anorgasmia, never had an orgasm. The main reason is because she really doesn't know where to be stimulated. And a sexual therapist can be very helpful in working through that, how and where to stimulate, and then she can have her partner work with her. And that is associated with a 90% success rate. Even pain with intercourse, which can be a lot of things that we talked about, that needs to be thoroughly worked up, and it is very highly treated. And the vaginismus, you should know it's the only sexual dysfunction diagnosed by physical exam, and that can be very highly treated with the vaginal dilators that I showed you the picture of. Okay, let's spend a few minutes on sexual assault. Every 2 minutes, someone is sexually assaulted in America. 683,000 rapes every year, 56,000 rapes every month, 1,800 rapes every day. I mean, this is a big, big issue. Sexual assault. And often this is not reported. There are rape kits which are available or should be available in the emergency department, and we'll talk about that coming up shortly. These are very sobering statistics. Percent of women exposed to violence or abuse, 16% childhood abuse, 21% rape or assault, 30% domestic abuse, any violence in a lifetime. This is big time issues. 1 out of 5 women have been raped or sexually assaulted. And here's our case. A 21-year-old university student presents to the emergency department stating she was walking home after an evening class when she was assaulted by a male stranger and was raped. She's not crying, not upset, but looks without emotions. Why not? Why doesn't she have any emotions? Because she's in shock. Okay, that's a very common finding. She's accompanied by her female roommate. So, what do we do? At Loma Linda University, we have sexual assault examiners training workshops. It's not just the family practitioner on call or the OBGYN on call or the emergency department on call. There are special training which is available. And this is a sexual assault nurse examiner training. And there's a certification which you can get. And these kinds of problems need very specialized care. You must remember that rape is sex under coercion. Coercion is not a medical judgment. This is a legal judgment. Was this consensual or was it coerced? Kobe Bryant, who is one of the stars of the LA Lakers, was accused of having sex with a woman in Eagle, Colorado. You may remember this. The question was not, did he have sex with her? He admitted he had sex with her. But he said it was consensual, and she said it was coercion. Who decided whether it was coercion or whether it was consensual? It wasn't the doctor. That's not the medical system. That is the legal system that does that. So when a patient says, I was raped, you don't argue with her. You state in her own words that she says that she was raped. And then you need to document. Document what you find. Photos would be best, drawings if you can't do that. And here is a diagram which you can use for recording physical findings on an adult. And here is on a child. This just shows some of the specimens that you need to get in the rape kit. Comb pubic hair, pluck pubic hair, 4 vaginal swabs, vaginal smears for sperm, vulvar smears for sperm, all kinds of different things, and they need to be collected properly. They need to be sealed. Then they need to be transferred over to an appropriate authority. And if that's not done properly, the evidence can be declared inadmissible. So it really needs to be done properly and carefully. And then document if there is any injury, if there is any contusions. Here's a swabbing of the areola after oral contact by the assailant, cutting some pubic hair. Now, here you can see is the perineum, perineal body. This is the anus, this is the vagina, and you can see this is red. Okay, it's erythematous. Was this consensual or was it coercion? And you don't know. You don't know because you can have gentle sex, you can have vigorous sex. Here, if you look carefully, you can see that there is a little superficial laceration of the perineal body. Again, your role is to describe what you saw. To describe what you saw. The OJ case is a good example. The specimens were declared inadmissible because they weren't transferred properly. And if the woman would need to or wants to proceed to prosecute, you need to have that evidence there. Okay, antibiotic prophylaxis, gonorrhea, we use cefixime, chlamydia, we use azithromycin, trichomoniasis, we use metronidazole, hepatitis B, the HIV even use antivirals and pregnancy prevention, Plan B. So these all need to be considered. And of course, any injuries need to be properly taken care of. The CDC now recommends HIV drugs for all rape victims. And that is now the standard of care. And here's the Plan B. We talked about this. Now, here is this gentleman who is talking to this lady, And it's not the lady saying, I'm on the pill. It is the man who's saying, I'm on the pill. So, what pill is that? Well, these are men who are waiting in line to get their Viagra and here are the ladies going to see a romantic movie. It's the blue pill, and there it is. Life will never be the same since Viagra. Of course, there are now other competitors as well, Levitra and Cialis, and you've seen these ads on TV. Will you be ready? Look at the difference in the size of these bathtubs. I never noticed that before. Anyway, the generic name for Viagra is sildenafil. How does it work? You should know this for the exam. It inhibits phosphodiesterase 5, which is an enzyme which degrades the cyclic guanosine monophosphate, which relaxes smooth muscle in the corpus cavernosum of the penis, resulting in vasodilation and erection. The sildenafil was originally used to try to relax the smooth muscle in the blood vessels of people who had pulmonary hypertension. And did it work? Well, it really didn't do much for the pulmonary hypertension, but the gentlemen who were on the study protocol and who had the sildenafil came back and said, by the way, do you have any extra of that? And that's where the billion-dollar industry came from. So if we have those kinds of drugs for men, do we have them for women as well? And initially, the report was that Viagra works for women as well as men. This was a 12-week study of 210 postmenopausal women. But when Pfizer enlarged the studies to look at 3,000 women, they ended the testing because they said it does not work. And you know why it doesn't work? It's because women are far more complex. Men are so simple. This is a woman's sexuality. You want to see what a man's sexuality looks like? There it is. The women and men. See, if you look at the erogenous zones of a woman and compare them to a man, a woman is far more complex than a man. Much more. Different meanings for love. Okay, let's go to chapter 11, which is menstrual abnormalities. And we will start out with a review of menstrual physiology. Okay, we need chapter 11, and that looks like chapter 12. Okay, let's go with menstrual abnormalities. I want to first review menstrual physiology. And let's look at the handout. We want to look at menstrual cycle hormones, and we can see how we could have problems potentially at many different levels. We start out with the hypothalamus. The hypothalamus secretes what hormone? GnRH, gonadotropin releasing hormone. That travels through the hypophyseal portal circulation in the brain to the anterior pituitary. The anterior pituitary is stimulated by GnRH to release FSH. FSH goes through the general circulation and specifically goes to the ovarian follicle. In the ovarian follicle, the FSH stimulates the ovary to produce estrogen. Now, estrogen feeds back to the anterior pituitary, and so you have a negative feedback relationship. The ovarian follicle also makes inhibin, and inhibin feeds back to the anterior pituitary. So we've got two hormones which will keep a balance in the secretion of estrogen. It is the estrogen, and that's specifically estradiol in the non-pregnant reproductive years, and inhibin. Now, the estrogen, as it rises, is going to stimulate, it will produce the endometrial proliferation, but as it rises, it will at some point lead to the LH surge. And you'll hear me talk about that a lot this evening. It is the rise in estrogen which is needed for the LH surge, because without the LH surge, you will not have ovulation, and without ovulation, you will not have the corpus luteum. The corpus luteum produces progesterone, and progesterone goes to the endometrium and brings about secretory changes, which are enhancing the implantation of the blastocyst. So it's the estrogen and then the progesterone. If there is no pregnancy, if there is no HCG, the corpus luteum says, why should I bother making this this progesterone? I'm going to quit and go home. And progesterone levels will start to fall. It is the progesterone withdrawal which leads to spiral arteriolar spasm, necrosis, release of prostaglandins, and then finally the menstrual flow, the endometrial shedding. So you can see how we could have problems from the hypothalamus, from the anterior pituitary, from the ovary, from the endometrium, and from the outflow tract. So there are many levels at which we can have potential problems. All right, this is in your book on page 229. We're going to look at menstrual physiology from the standpoint of the gonadotropins, which is FSH and LH. We're going to look at it from the standpoint of the ovarian steroids, which is estradiol and progesterone. We can look at it from the standpoint of the ovarian follicle, the follicular phase and the luteal phase, and we're going to look at it from the standpoint of the endometrium. So let's look at the endometrium, and we're looking here at the days of the cycle. And here we have 28 days on the average. The mid-cycle is 14 days. The lower part of the endometrium, which is below the dotted line, is the zona basalis. This is the deeper layer. This does not get shed off. This is where the regeneration takes place from. And this is where the basal arteries are. And here you can see one right over here. Now, this part is the zona functionalis. This is the part that grows, that sloughs off. that grows and sloughs off. It is superficial. When there is a fall in progesterone, there is spiral arteriolar spasm, ischemia, release of prostaglandins, and sloughing off. Now, I want you to notice this is a spiral arteriole. 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 The spiral arteries are what go into spasm when progesterone falls. And that's what gives an orderly shedding of the endometrium. This is really important to understand that it is progesterone withdrawal which leads to the normal menstrual flow. Spasm with progesterone withdrawal, ischemia and necrosis, prostaglandins, and sloughing. So these are going to be cramping. The spiral arterioles are here in the non-pregnant woman. In pregnancy, they will normally dilate as there is invasion of the trophoblast that comes in here. You can see how the blood flow is markedly increased. It is less so in women who develop hypertension, and that's why we have the decreased blood flow, the IUGR. All right, we looked at this on the first day. Let me just review it again. The two main endocrine structures of the ovary are the ovarian follicle, which produces estrogen, the corpus luteum, which produces progesterone. So let's run through this once again. This is the follicle. It is stimulated by FSH. FSH causes the follicle to produce estrogen. Estrogen levels will rise. It is the rise in estrogen. Why is it that women with polycystic ovarian syndrome do not have ovulation? It's because the estrogen levels, although they are high, are not rising. They're stable, they're tonic. It is the rise which is necessary for the LH surge. The LH surge results in extrusion of the egg, ovulation, and the site of ovulation will become the corpus luteum, and the corpus luteum produces progesterone. When progesterone falls, when the corpus luteum involutes, if there is no HCG and no pregnancy, what happens? That's where we have the spiral arteriole spasm, necrosis, prostaglandin release, cramping, and sloughing. That is a progesterone withdrawal period. That's a normal period. That's the mechanism of normal endometrial shedding. Okay, the ovary. The ovary we can divide in the menstrual cycle into the follicular phase, dominated by the ovary, the follicle which secretes estrogen, and then the last part is the luteal phase, which is dominated by the corpus luteum that produces progesterone. Follicle, corpus luteum. And this is in your book on page 229. Nice colored pictures. Also, we can talk of the follicular phase as the proliferative phase and the luteal phase as the secretory phase. Okay, then we can look at it from the standpoint of the gonadotropins. In the first half of the cycle, in the follicular phase, it is FSH which is dominant. And you can see FSH rises and then drops. In the second half, it is the corpus luteum, and it is the LH surge which produces the beginning of the luteal phase. So you have FSH early and then LH in the middle. In a 28-day cycle, the LH surge occurs on day 14. And this is the beautiful colors in your notes. Okay, the ovarian steroids. In the follicular phase, we have estrogen. In the luteal phase, we have progesterone. And let's see how they rise and fall. So this is really important. It is the rising of estrogen right here that is essential for the LH surge. Without the rise, you don't have the LH surge. So we have a rise in estrogen, then a drop, and then a bimodal secondary rise, which is the secretion of estrogen by the corpus luteum. But you can see the progesterone is primarily in the second half. Now, notice the progesterone goes up and up and up until the middle of the luteal phase. The corpus luteum looks around and says, is there any HCG around? Because if there's not any HCG, that's when the corpus luteum says, let's forget it. Let's stop making progesterone, and the progesterone levels fall. And when they reach a certain critical threshold, that's when you have the spiral arterial spasm. And this is in your book. Now, let's look at the endometrium. All right, in the endometrium, if you would remember, estrogen is the accelerator. This produces a heavy, hyperplastic, and unstable endometrium. That's in the proliferative phase. Progesterone is the brake. It stabilizes the endometrium. That's why, and we'll talk about this later, when you have anovulatory bleeding, when you give progesterone, it stabilizes the endometrium and stops the bleeding. That's in the secretory phase. With the fall in progesterone, the spiral arterioles constrict, the prostaglandin is released, necrosis. Okay, this is basically the same. Okay, look at what happens if all we have is estrogen. If all we have is estrogen, the lining gets thicker and thicker. And look at the pattern of bleeding. There's no predictability. There can be huge amounts of bleeding for a long period of time, a small amount for a long period of time. I mean, it is totally unpredictable. That is the classic finding with anovulation. And over time, it can lead to a lot of blood loss because it's not limited because of the spiral arteriolar spasm. Now, what do? We give progestin, and notice how the bleeding stops. Then you have a limited 5-day period, and we give another 7 days of progestin. And can you see what's happening now? The hyperplastic endometrium is coming down and down until finally it's back down to where it should be. So that's why progestin is used to stabilize endometrium and return it to its normal state. All right, the last thing before we show the diagram, which we'll put it all together, I want you to notice that the follicular phase can be divided into 2 parts. This is the follicular phase, the follicle. In the first half, there are many follicles that are recruited. And FSH is rising. You see it's rising here? Around the middle of the follicular phase, there is one follicle which becomes dominant. And we call that the dominant follicle. And the other follicles will then undergo atresia. Because there is an increasing number of FSH receptors in the dominant follicle, even though the FSH is falling, the estrogen continues to rise. Okay, let's see if we can put this all together. FSH is rising. What's the purpose of a rising FSH? Stimulation of estradiol. Estradiol starts rising. Here is where we have the dominant follicle. LH is down, very, very basic. Even though FSH is falling, the dominant follicle continues to make more and more estrogen. You see this right here? If we have a rise in estrogen for 50 hours or more, what will that do? It results in the LH surge. The LH surge results in ovulation. Ovulation results in the corpus luteum. The corpus luteum produces progesterone. And so here we have progesterone. And it rises and rises and rises until the middle of the secretory phase. Then it looks around and it says, is there any HCG? If there is no HCG 7 days after ovulation, the corpus luteum starts to regress, progesterone levels start to decline, and when they reach a critical level, that's when we get the spiral arteriolar spasm, we get the release of prostaglandins, necrosis, and the menstrual period. I've had OBGYN physicians in practice for 20 years who, when they heard this explanation, they said, finally, I understand how this works. And we'll work through this quite a bit over the next few hours. Okay, let's start with premenarcheal vaginal bleeding. This is a pre-pubertal girl. An 8-year-old is brought by her mother to the office because of vaginal bleeding for 2 weeks. The girl is not taking any medications and gives no history of sexual abuse. What medications could she take that could lead to vaginal bleeding? What if she took her mother's oral contraceptive pills? Estrogen. And then when she stops, she could bleed. None of that. No history of sexual abuse because you could have bleeding from injury from that. Now, no headache, no visual disturbances, doing well in school. Why do we talk about headache and visual disturbances? Because, and we'll talk about this in just a little bit, you could have a pathology of the brain, a sarcoid, a tumor, an infection, which could stimulate the GnRH secretion, resulting in precocious puberty. But she doesn't have any of that. On exam, she's normal for her age without pubertal changes. And this is really the take-home message right here. Pelvic exam under sedation reveals a vaginal foreign body. The most common reason for premenarcheal vaginal bleeding is a vaginal foreign body. So, bleeding prior to puberty, most common reason is a vaginal foreign body. If you don't find it, then you need to think, could there be a neoplasm? Have you heard of sarcoma botryoides? Sexual abuse, always a possibility. Ovarian, pituitary, adrenal tumor, we'll talk more about that. The diagnosis is going to be made by pelvic exam under sedation. I had a student who went to another institution and came back and said that they did an exam on this child, and it took 4 people to hold her down. I said, you must be crazy. You don't hold down a child, you sedate them. Can you imagine the trauma that could result from that? If you don't find anything, then of course you need to do a further workup. This is a straddle injury where we have a penetration of the perineal body of a young girl. Obviously, a pelvic exam will show this. This is a rhabdomyosarcoma that is coming out of a pre-pubertal girl's vagina. This is a 3-year-old girl who put into her vagina broken pieces of bangle, small wooden sticks, wheat husk, and wheat grain. And you say, why would you do that? Well, if you've got an opening, why not put something in it? Here is a 8.5-year-old girl, and they're taking out a 4-inch section of a pencil. And here is a 3.5-year-old girl, and she had some safety pins that were put in her vagina. Anyway, just remember foreign body. Okay, abnormal vaginal bleeding. Here's our case. A 31-year-old patient complains of menorrhea. That's a big word, menorrhea. Metrorrhagia. What is that? It is irregular, unpredictable, and heavy bleeding. It really is more of a descriptive term. It doesn't give you an etiology. The most likely explanation for unpredictable heavy bleeding is a hormonal problem and lack of progesterone, which is an ovulation. Her menarche was at age 13, which is pretty average. She has had regular menses until the past 6 months. Pelvic exam, including a pap smear, is normal. So where do we go with this if you have a case? Now, I already showed you this. It's important to remember the history. If we have regular, predictable cycles with cramping and bleeding between, you think more of an anatomic lesion. Irregular bleeding between normal cycles. If the bleeding is unpredictable and irregular and no cramping, then you think of a hormonal problem. The most common hormone missing is progesterone. See, if you have missing estrogen, you can have amenorrhea, not abnormal bleeding. Okay, this is on page 230 in your book. First thing you must think of is pregnancy, anatomic lesion, inherited coagulopathy, and dysfunctional uterine bleeding. Let's look at the cheat sheet at our handout, and it should make that clear. NSAIDs, tranexamic acid, endometrial ablation, hysterectomy. Let's talk about that. Okay, let's start from the top. Abnormal menstrual bleeding. First thing you should always do is a speculum exam. I've mentioned this many times over the last couple of weeks. Anytime you have bleeding, you should do a speculum exam. Then do a beta HCG. Is there a pregnancy complication? And we talked about threatened abortion. We talked about inevitable abortion. We talked about molar disease. We talked about ectopic pregnancy. Anytime there is abnormal bleeding, could it be a pregnancy complication? So easy to rule out a beta HCG. Then I put here in a dashed line, think at least of inherited coagulopathy. One of the most common ones, although it's not common, is von Willebrand's disease. And just measure von Willebrand's factor. You don't necessarily need to do it for all patients, but at least think of it. It's interesting. Von Willebrand's disease is named after a Finnish doctor who lived on an island off the coast of Finland. And the woman who had the von Willebrand's disease and family history was positive for bleeding, ended up dying because of excessive bleeding, and it was menstrual bleeding. So, speculum exam, beta HCG, think could it be a von Willebrand's disease? And this often will show up around the time of adolescence and menarche. Okay, now let's distinguish between ovulatory cycles and anovulatory cycles. Ovulatory cycles, if you remember, is bleeding between regular, predictable cramping. The bleeding in between, there's no cramping. That is more likely to be associated with an anatomic lesion. We've already ruled out a vaginal cervical lesion, so now we have to see, is there a upper reproductive tract, a intrauterine lesion? And that's where we do the hysteroscopy. And if you find an intrauterine polyp, if you find a leiomyoma, you resect it. I showed you the video of what that looks like. Remember, these cycles are probably ovulatory if there is cramping and irregularity. What is the difference with anovulatory cycles? Irregular, unpredictable, no cramping. Do you understand the difference between these two? Okay. If it is irregular, unpredictable bleeding without any cramping, we can make a working diagnosis of anovulation. And so we will use a progestin trial. Medroxyprogesterone acetate, Provera for 7 days. What should happen? The menses should normalize, no more bleeding, the bleeding stops and stays stopped until you finish the progesterone, and then you have a normal limited withdrawal bleed. If that's what happens, we make a presumptive diagnosis of anovulation. So it is a progestin trial which should stop the bleeding, which will confirm anovulation. If on the exam you read the patient had a positive progestin trial, you know the diagnosis was anovulation. Okay, if it is anovulation, are there correctable causes of anovulation? Yes. There could be hypothyroid. We talked about that. Get a TSH. If TSH is high, then you want to give some synthroid. Is there a elevated prolactin? Could there be an antipituitary prolactinoma? That can be identified with imaging and can be corrected. If the TSH is normal, if the prolactin is normal, then we just say it is idiopathic, and we will just cycle her with progestin, hydroxyprogesterone acetate 7 days a month for basically ever. Really, what we're doing is we're not getting her to ovulate. If she wants to get pregnant and to ovulate, what would you give her if she wanted to get pregnant? You wouldn't give GnRH. You would give it clomiphene. Exactly. Goldie, you got it. Clomiphene is what. Let's follow this arrow right here. If we have confirmed anovulation, does she have hyperplasia? Well, the risk factors for hyperplasia and endometrial cancer we talked about yesterday: obesity, hypertension, diabetes. So if she's obese, hypertensive, diabetic, age over 35, let's do an endometrial biopsy. Is hyperplasia without atypia, medical atypia for 3 months, repeat the biopsy. If it is with atypia, that is premalignant, 30% will become cancer. That's where I would do a TBH and or a TAH. What if you give progestin and the menses do not normalize? That's when you want to think of other treatments. You can sometimes put a Mirena, in levonorgestrel intrauterine device, intrauterine system into the uterus, and that can stabilize endometrium. Tranexamic acid can do that, is a fibrinolytic agent. Use endometrial ablation, where you create iatrogenically an Asherman syndrome by cooking the endometrium, by barbecuing it, by lasering it, or by freezing it. I'll show you some pictures. This is the tranexamic acid. It inhibits fibrinolysis by plasma, not to be used in the history of blood clots, because that clots the blood. The Mirena or MPA can be used for heavy, and this is where the Mirena peak is much better in treating the bleeding than is the MPA. Abnormal bleeding, lower genital tract, we talked about that. Dilation, also EU that, and generically, we can describe abnormal bleeding as bleeding, which is, see, this looks at normal bleeding. It should be between 21 and 35 days. If bleeding occurs closer than 21 days, if it occurs over excessive, that's what would be called abnormal bleeding. This mitral lesion that you would see if you did a hysteroscopy. This is the provera. I showed you this picture before. Okay, this is we went over this before when we have endometrial cancer. Oops. Simple hyperplasia, no atypia, can be treated with progestin. Complex hyperplasia, no atypia, progestin. So medical treatment. Complex hyperplasia with atypia, I would like to do hysterectomy if she's finished childbearing. But I might use progestin if she's not a good surgical candidate. But endometrial carcinoma, TAHBS. So, but see, with unopposed estrogen, this is the sequence. Simple hyperplasia becomes complex hyperplasia without a hyperplasia with endometrial carcinoma. Now, this is endometrial ablation. This is where you put in the uterine cavity this balloon, you fill the balloon with fluid. A microwave will do, it will, and it basically burns it off. And so the bleeding will stop. You could use a cryotherapy where you freeze it 100 degrees below zero, and that will cause the scarring. So in the olden days, if there was bleeding unresponsive to hormone therapy, we would do hysterectomy. But now we can use these minimally invasive techniques and leave the uterus there. Now, this is in your book on page 232. It's in the margin. And I put it in there not because you need to memorize it, but it is looking at the causes of abnormal uterine bleeding using this mnemonic PALM, PALM, and coin, COEIN. Here's a palm and here's a coin. So polyp, adenomyosis, leiomyoma, malignancy, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. Now we've talked about all of these, but anyway, just you've seen it, so at least you have been exposed to it. And this is me in Cozumel, Mexico. This is called drift diving. The current will carry you along. You don't even need to swim. Marvelous. Okay, let's take our first 10-minute break. See you in 10 minutes. Okay, here we are on the second hour. All right, we're going to look at primary amenorrhea. Primary amenorrhea can be defined as no menses age 14 without secondary sex characteristics and no menses age 16 with secondary sex characteristics. And we can generally talk about secondary sex characteristics as breasts present, breast absent. So age 14 without breasts, age 16 with breasts. And what we're saying is that the average woman, young woman, will start to show secondary sex characteristics at least by age 14. And if she has secondary sex characteristics, she should have her menstrual period at least by age 16. So on the exam, if you have a presentation of a patient who is brought in at age 13 without secondary sex characteristics, do you do a workup? No, because she really doesn't technically meet the criteria. If she is 15 brought in by her worried mother, would you do a complete workup? No, because she doesn't meet the criteria. Okay, let's look at our case. 16-year-old girl is brought in by her mother because the girl has never had menses. That is primary amenorrhea. Secondary amenorrhea, we're going to talk about in just a little bit, is where she's had menses in the past, but now has stopped. All her friends in school have menstruated, and she feels kind of weird. On exam, she is well nourished. Now, this is a term used in the United States to say unremarkable. Well nourished, well developed. You may see that on the exam. Well developed, well nourished. It really doesn't, don't overread into that. It just means that she's normal. She has adult breasts and pubic hair. What this tells you is that she has estrogen around, adult breasts, and the pubic hair tells you that she has androgen receptors. Pelvic exam reveals a rudimentary vagina, so she has a shortened vagina. No uterus is palpable on a rectal exam. So, what are you thinking as a possible diagnosis here? It is not androgen insensitivity, because androgen insensitivity patients wouldn't have pubic hair. But malarian agenesis would make very good sense, because she would have adult breast pubic hair, but no uterus. Okay, let's go on and we'll see how we work up. This is our handout, and we'll start out with up here. We want to group these patients into groups based upon breast present or breast absent, uterus present, uterus absent. And we can come up with three categories. The first would be breast present, uterus present. Pelvic exam should give us the diagnosis. This should be quite straightforward. The three diagnoses you should consider, and I'll show you pictures: vaginal agenesis, vaginal septum, intact hymen. These are normal karyotype 46XX. If it is vaginal agenesis, you can create a vagina artificially, either surgically or with dilators. If there is a vaginal septum, you can surgically remove the septum. If there is an intact hymen, you can make an incision in the hymen. So, breast present, uterus present, diagnosed by pelvic exam, and this is surgical management. All of these are surgical management. Next, we'll look at breast present, uterus absent. Breast present means that there is estrogen. So why isn't there a uterus? A screening test that we can use is testosterone. Is it normal male or is it normal female levels? If it is normal female levels of testosterone with breast present, uterus absent, it is probably Müllerian agenesis. You need to get a karyotype, 46XX, to confirm that it is normal. Because the Müllerian system contributes to the fallopian tubes of the corpus of the uterus and the cervix of the uterus and the proximal vagina, those will be gone. But what will be present is the distal vagina, which is from the urogenital sinus. So that will be present, short vagina. No surgery is needed. You can, using dilators and pressure, lengthen the vagina to where it is functional. There is no treatment, no estrogen, no progesterone, because she has normal rising and falling. She has normal FSH, GnRH. The only thing she doesn't have is a uterus to show the proliferation and to have the sloughing off and to be able to get pregnant. If she wants to have a baby of her own, she needs to have a surrogate mom. What if the testosterone levels are elevated for a woman, but they are normal for a man? That would be androgen insensitivity. This is a X-linked recessive. We talked about that on the first day last week. 46XY, so this is a genetic male, but there are no androgen receptors. If there are no androgen receptors, the body doesn't know androgen is there, and the Wolffian system then just atrophies. Because there is testes, which is usually in the inguinal canal, there is Müllerian inhibitory factor, which will cause regression of the Müllerian system. So you won't have a Wolffian system, you won't have a Müllerian system. Short vagina, you need to remove the testes because the testes can become malignant sitting in the inguinal canal. When you take out the testes, then she needs estrogen because the testes were making both androgens and estrogens. But she needs no progesterone because she has no uterus. So there's no endometrial hyperplasia risk. Next, we'll go over here, breast absent, uterus present. Breast absent means we have low estrogen. What single test will tell you that the estrogen, why the estrogen is low? And it is an FSH. If the FSH is high, we call this hypergonadotropic amenorrhea. This is probably gonadal dysgenesis, Turner syndrome. Karyotype is 45X. Short stature, we already showed you that picture. She cannot have a pregnancy of her own because she has no follicles. Now she could have embryos transferred by an egg donor. But she wants to look like a woman. You can help her look like a woman. You need to give her estrogen, but also progesterone because she has a uterus. If the FSH is low, it's going to be hypothalamic pituitary axis failure, normal karyotype, normal height. She has eggs, but they're not aged. So you can use human menopausal gonadotropin and that will allow her to be pregnant. You can give her characteristics by giving estrogen, but also progestin because she has a uterus and she could get hyperplastic. Okay, let's look at breast present, uterus present, hymen, transverse vaginal septum. These are usually obvious causes, diagnosed from physical exam. This is the end of this woman's vagina, right here. Very short, congenital absence of the vagina. This needs to be surgically managed. This is intact hymen. What's behind the hymen bulging out here? It is the menstrual flow that cannot get out. So you make a cruciate incision, a cross-shaped incision, and you can get the drainage out then of the menstrual flow, which has never been able to get out before. Transverse vaginal septum. Here you can see the uterus, the cervix, the proximal vagina. This arose from the Mullerian duct. The distal part of the vagina arose from the urogenital sinus. If there isn't patency between these, you can have a transverse vaginal septum. Here's another one. Now, you should be able to see this with speculum exam. And this can be surgically removed. Now, this is not a transverse septum. This is a longitudinal septum. This is because you have failure of fusion of the Mullerian ducts from either side. Primary amenorrhea, breast present, uterus absent, Mullerian agenesis, androgen insensitivity. This is in your book on page 233. Why is the uterus absent? With Mullerian agenesis, normal karyotype, idiopathic. The estrogen comes from normal ovaries. Pubic hair is present because there are normal androgen receptors. Testosterone level is not elevated, it's normal female. And she has no hormones needed, no estrogen progestin because she's making her own. A vagina can be created surgically. And she needs a surrogate mom who can carry her IVF embryos. Androgen sensitivity, the uterus is absent because there is Mullerian inhibitory factor coming from the testes. The testes also produce estrogen. And if the body can't respond to the androgens, it responds to the estrogen. So these are males, genetic males, who respond to the estrogens. And they look like women. They are women mentally, their sexual identity. Pubic hair is absent because we don't have androgen receptors. Testosterone level is high, male levels. You take out the testes and just surgically. This is in your book on page 233. Mullerian agenesis, pubic and axillary hair present, breast present, but uterus absent. Pubic and axillary hair absent, breast present, uterus absent. That would be androgen insensitivity. Okay, Mullerian agenesis, also known as Mayer-Rokitansky-Kuster-Hauser syndrome. I know you really wanted to know that. If you look on the, looking at the pelvis from the top down, you see normal rectosigmoid. This is the ureter, which is coming over the pelvic brim. You have normal ovaries, bladder here. But what's missing? It's the fimbria, the fallopian tube, the corpus of the uterus, and the proximal vagina. This is Cherelle. Cherelle does not have a uterus. This is Shannon. Shannon does have a uterus. Shannon is a surrogate mom for Cherelle. Shannon is carrying IVF triplets for Cherelle. The babies are from Cherelle's eggs and her husband's sperm. Shannon here is 29 weeks, has been hospitalized for almost 2 months. Cervix was only 5 millimeters long. Concern about preterm labor. Here is moi, and here are the ladies. And actually, everything turned out very well. Cherelle was from New Zealand, and in New Zealand, it is illegal to pay somebody to be a surrogate mom. So she came to California. And here we are. Shannon was an amazing woman. Surgical creation of a vagina. You can do this. Don't do it until she is wanting to be sexually active because you can get scarring otherwise. This is the stent, which is used with a skin graft. Androgen sensitivity used to be called testicular feminization. This is an X-linked recessive. These are sisters, but they are genetic males. Notice they have no pubic hair, but they look like females. They function as females. Their sexual identity is females, but they cannot have any children. This woman is holding up her arm to show no axillary hair, And these are the testes which were removed from the inguinal canal. Now, look at these people. Do they look like men or do they look like women? These are all complete androgen sensitivity, and they are women, even though they are 46XY. Same here. Some people think that Jamie Lee Curtis has it. You look on her website, it doesn't deny it, but it doesn't say she does. She has children, but they are adopted. So there you go. Breast absent, uterus present, gonadal dysgenesis, hypothalamic pituitary failure, gonadal dysgenesis, high FSH. There's no ovarian follicles to make estrogen, so there's no feedback to lower the FSH. There are streak ovaries. Treatment, you need to give her estrogen and progestin so she can have secondary sex characteristics, but she can only have pregnancy with an egg donor. The hypothalamic axis failure, normal karyotype, low FSH, because of some problem in the brain. So the follicles are not stimulated, normal ovaries, you can make her look like a woman, estrogen plus progestin. You can bring about ovulation induction by giving her HMG, human menopausal gonadotropin, which acts like FSH. But now you need to find out what's going on in her CNS that is causing this problem. This is on page 233 in your book. Remember, FSH levels high, it's going to be ovarian follicular problem. FSH low is going to be hypothalamic pituitary. You can take that to the bank. Turner syndrome, you saw this picture before. Short stature, no secondary sex characteristics, and there's no ovaries, there are only streak gonads. Would you like to be an egg donor? $7,000 to $10,000. Now, this is not as simple as being a sperm donor because you have to have ovulation induction, hyperstimulation of the ovaries, and then you have to have aspiration through the vagina under ultrasound guidance and anesthesia to get the follicles and the eggs out of the follicles so that you can have IVF. Hypothalamic pituitary insufficiency, Kallmann syndrome, isolated GnRH deficiency associated with anosmia. That's difficulty in smelling. And this is an X-linked recessive in females. So Kallmann syndrome would be an example of breast absent, uterus present because of a CNS issue. Okay, Cozumel, Mexico. All right, our next topic, secondary amenorrhea. And here is our case. 32-year-old woman states her last menstrual period was 1 year ago. Now, technically, the criteria for secondary amenorrhea is no menses for 3 months if previously regular menses, no menses for 6 months if previously irregular menses. So here she is without a period for 1 year. So that meets the criteria, whichever her menses were previously, irregular or regular. Menarche was age 12, which looks about right. She was initially irregular, but since age 14 or 15, menses were every 28 to 29 days. So initially she was anovulatory. That's what we'd expect. No cramping. When she starts ovulating, then she has predictable menses. but now she has a cramp. She's never been pregnant, has not been sexually active, and has not used contraception. I would hope if she's not been sexually active that she wouldn't be pregnant. Physical and pelvic exam is normal. All right, where do we go? There's only 4 causes of secondary amenorrhea: pregnancy, anovulation, estrogen deficiency, and outflow tract lesion. So let's sequentially go through this. Pregnancy, anovulation, estrogen deficiency, outflow tract obstruction. Okay, here's our handout. The first thing you want to do, secondary amenorrhea, beta-HCG. You don't do a speculum exam for secondary amenorrhea. Primary amenorrhea, yes. If we have heavy menstrual bleeding, yes. But in this case, we do a beta-HCG to find out, could she be pregnant? If she's pregnant, well, then that answers it, and then you can do the workup, whatever that involves. If the beta-HCG is negative, then we go to a progesterone challenge test. We're looking at a hormonal problem, a hormonal deficit. What hormone is missing? It is progesterone. If progesterone is missing, what else is missing? Its ovulation is missing. So this is consistent with anovulation. Lack of progesterone. So the endometrium may be estrogen primed, but there's nothing to cause the spiral arterioles to constrict and get necrosis and shedding. So what we do here, secondary amenorrhea, beta-HCG is negative, we give progestin. Medroxyprogesterone acetate, MPA, 7 to 10 days. You could give 150 milligrams of progesterone in oil and injection. And if you have any bleeding within the next 3 to 7 days, we would call that a positive progesterone challenge test. If there is a bleeding, we call it a progestin trial. This is a progesterone challenge test. So if it is anovulation, a lack of progesterone, then we need to find out, we've talked about this just a few minutes ago, is there a correctable cause of anovulation? Is there hyperthyroidism? Is there hyperprolactinemia? If there is, you treat those. If TSH is normal, if prolactin is normal, then we assume it is idiopathic. And the management will be MPA, cycling, 7 to 10 days a month to prevent endometrial hyperplasia. You could put her on just combination oral contraceptives, but does she really need the estrogen? No, it's a progestin, but sometimes just for ease of administration, that's what we do. If she wants to get pregnant and she's anovulatory, then we'll give her clomiphene citrate. How does clomiphene work? Clomiphene is an anti-estrogen. It feeds back to the anterior pituitary and says, we don't have enough estrogen. So what does the anterior pituitary say? Okay, here's some FSH. We'll give you a little bit more FSH. And the FSH starts rising. As the FSH starts rising, what happens to the estrogen? The estrogen starts rising. And when the estrogen rises for 50 hours or more, boom, LH surge, ovulation. Okay, let's say the progesterone challenge test is negative. Then we do an estrogen progesterone challenge test. In other words, we give the woman estrogen that will prime the endometrium, proliferate it. We give progesterone either sequentially or we could give them both together. And once you stop it, if she has a bleed within 3 to 7 days, it will be called a positive estrogen progesterone challenge test. Now, what does that mean? This means it was low progesterone. This means low estrogen. You see, the reason why she doesn't have any bleeding is because there isn't enough estrogen to stimulate the endometrium to respond to the progesterone. So if your 65-year-old grandmother who has an anatomically normal reproductive tract hasn't had a menstrual period for 15 years, if you gave her estrogen and progestin, what should happen? She should have a menstrual period. Why didn't she have it? Because she had low estrogen. So we need to do an FSH to see why the estrogen is low. We just talked about this, right? If the estrogen or if FSH is high, it has to be ovarian follicular failure. You can take that to the bank. It is always ovarian follicular failure if the FSH is high. Now we need to find out why. Let's do a karyotype. If she is young, could she have a mosaic, maybe a Turner's mosaic? And she needs estrogen plus progestin to maintain secondary sex characteristics. If the FSH is low, you know it's got to be hypothalamic pituitary. It is hypogonadotropic. This is hypergonadotropic. She needs estrogen and progestin as well, but she needs a head CT to find out what's going on in the hypothalamic pituitary. If she has hypothalamic pituitary axis failure, such as Kallmann syndrome, then we use human menopausal gonadotropin to induce ovulation. Okay, beta HCG negative. Progesterone challenge test, no bleed. Estrogen progesterone challenge test, no bleed. What's left? Yeah, what's left is an outflow tract obstruction. The estrogens are going up, the sloughing is taking off, but the flow cannot get out. How do you find out where the obstruction is? Hysterosalpingogram. And the two main issues would be cervical stenosis, in which case you would do surgical dilation to open up the stenosed canal, or Asherman syndrome if she has scarring in the endometrium, and I'll show you how you do that: hysteroscopy, intrauterine stent, and high estrogens. Okay, if we have anovulation, it can show up either as amenorrhea, that's what we just talked about, or menorrhagia. Now, how could anovulation be associated with both no periods and heavy periods? And here's why. See, initially, if all you have is estrogen, the lining starts proliferating, and we get thicker and thicker and hyperplasia, simple hyperplasia, and finally the lining gets so thick it has no structural support. It starts shedding irregularly, and that's that irregular bleeding because there's no spiral arteriolar spasm, there's no release of prostaglandins to stop the bleeding. It can go on for days and days and days and even weeks. So initially it is amenorrhea, and then it becomes menorrhagia. Okay, we can look at secondary amenorrhea based upon FSH levels. If it is hypogonadotropic, it is always hypothalamic pituitary dysfunction. We talked about that. And you need to do a head CT. If it is hypergonadotropic, FSH is high, the only explanation is ovarian follicular failure. Something has happened, and you don't have the feedback to shut down the FSH, and so the FSH goes very high. Eugonadotropic is normal FSH, and that would be associated with pregnancy and ovulation anatomic obstruction. But this would be a good board question. So what do you think is the FSH level in this woman? Anorexia. This is amazing. If you look here, this website says anorexia for life. This is encouraging young women to be anorexic. This is a potentially lethal problem. She is hypogonadotropic And that's why you don't see pregnancy in anorexic women. Do you think this is beautiful? Does this look beautiful? I don't understand why these fashion designers promote using these kinds of models. Yeah, it's scary. This woman, Isabelle Carrot, was a French model. She had anorexia. She volunteered for an anti-anorexic campaign, and this was her posing nude to try to draw attention to the problems with anorexia. But she couldn't deal with it herself, and she ended up dying at age 28. Unnecessary. This normal woman looks in the mirror and says, I'm fat, I'm too fat. And you tell her, honey, you're not, you're normal. And what does she say? You're lying. You're lying. You know, this is a very difficult problem to treat. This really calls for the best psychiatrist to work with this kind of situation, because what's in your brain is hard to change, your body image. Okay, on the exam, if you should see a case and it says positive progesterone challenge test, what is your diagnosis? Every time it's going to be an ovulation. An ovulation. If you see estrogen progesterone challenge test is positive, what is your diagnosis? Every time it's going to be low estrogen. Low estrogen. You can take that to the bank as well. Estrogen progesterone challenge test is negative. There's only one diagnosis which it can be, and that is exactly outflow tract obstruction. And this is what you would assess with a hysterosalpingogram. So this is a hysterosalpingogram. You put in the cervical canal this introducer, you inject the dye. The dye goes through the thin proximal tube, goes into the thicker outer tube, it spills into the pelvis. Here you can see the endometrial cavity, but do you see here there's a filling defect? That's a partial endometrial adhesion. But look at here, the cervical canal. You see no fallopian tubes, you see no spillage of dye. This is consistent with complete Asherman's syndrome. The entire uterine cavity is obstructed with these adhesions. So you can treat this using a hysteroscope, an operative hysteroscope. You look in the uterus and you find these adhesions. Now, these are partial adhesions. And so you will break these down with your operative hysteroscopy. You put in the uterus this balloon stent. It's got a triangular shape, so it goes into the uterine cavity. And when you inflate it, it holds the walls apart. You give high dose estrogen to stimulate, if you can, any remaining endometrium, and you hope that you will get some sort of response. It depends on what the cause was. If it was from a DNC, you have a very high likelihood of response. If it was from a myomectomy and you've got scarring of the endometrium, that can be much more difficult. So that is secondary amenorrhea. Okay, and if we could get ready, Amanda, for chapter 12, hormonal disorders. All right, remember pregnancy and ovulation, low estrogen, outflow tract obstruction. I hope you will take these handouts that I've given you and really fix them in your brain so you can get access to them on the exam. And this is a hawksbill turtle. I have a friend who is PhD marine biologist, and he's devoted his life to studying these turtles off the coast of Honduras in Roatan. And he puts GPS locators so we can follow where these turtles go. Really interesting. Okay. Then we will go to hormonal disorders, chapter 12. Thank you, Amanda. Okay, we're going to start with precocious puberty. Now, this is my daughter in 1975. This is my daughter in 2000. She did not have precocious puberty. Just wanted to show you. And now this is her daughter. Do they look similar? She's got more of a chubby face, I think. Anyway, this is my granddaughter. And this is another one. Okay, let's look at our case. A 6-year-old girl is brought to the office by her mother, who has noticed breast budding and pubic hair development on her daughter. Her childhood history is unremarkable until 3 months ago when these changes began. 6 years old, breast budding, and pubic hair. Why are girls growing up faster? Why is there early puberty? And there's no question that that is taking place. Is it hormones? Is it fat? Is it something in the water? Is it McDonald's hamburgers? The beef is being fed with hormones. What's the cause of this? The age of puberty, or the first menstrual period, has fallen from age 17 to age 12 and a half. So, what is it that causes the pubertal changes? See, normally we should have very low levels of FSH in a child. Low levels of FSH stimulate very low levels of estrogen. And yet the hypothalamic pituitary axis is so sensitive that even low levels of estrogen will suppress FSH. In puberty, there is a changing of the sensitivity of the hypothalamic pituitary to where it takes higher and higher levels of estrogen to suppress FSH. So FSH will start to rise. As FSH starts to rise, it stimulates the follicles to produce estrogen, and estrogen is what causes the first change, which is breast budding. Now, what we do know is that girls who are blind will develop puberty later than girls who can see. Girls who grow up in the northern climate, such as northern Finland or Scandinavia, Sweden, they will develop puberty later than girls who grow up around the Mediterranean area. Is it light darkness? We know that girls who are obese will develop puberty before girls who are more lean. Is it body mass index? Is it percentage of body fat? We really don't understand. What we do know, however, that they are occurring earlier. And this is looking at the prevalence of breast development by race. And this is white girls, which are in the green, and African American, which are in the blue. So even 8 to 9-year-olds, 35% of Black girls and 10% of white girls will have breast development. And even earlier than that. And it isn't entirely clear why this is happening. Pubic hair development is very similar. Now, we know that there are consequences of precocious puberty. The big issue that we think of is short stature, because you have premature closure of the distal epiphyses of the long bones. But this is an article. Early puberty may increase the risk of heart disease for women. This is precocious puberty, and you can see breast development and short stature. This little girl, and you can see, has elevated estrogen levels. She's got breast development. Okay, we need to differentiate between incomplete and complete precocious puberty. The changes of puberty are thelarchy, breast budding, andronarchy, pubic and axillary hair, menarche, the first menstrual bleed. If it is incomplete precocious puberty, either breast budding or pubic and axillary hair or bleeding, but not all of them, the management is observation, because what these may represent is not excessive levels of the hormones, but high sensitivity of the end organs, such as the breasts or the pubic and axillary hair areas. So incomplete observation, but if it is complete, which means all of these have occurred, thelarchy, andronarchy, menarche, then we need to do the workup. All right, let's look at our handout. First, diagnosis. Puberty, age less than 8. In boys, less than 9. And yet, as I showed you, the studies suggest that many girls, particularly black girls, will have pubertal changes before age 8. So we're going to look at idiopathic CNS pathology, granulosa cell ovarian tumor, McEwen-Albright syndrome. We're going to start with gonadotropin dependent, which means that the FSH is high. What should be the FSH in a pre-pubertal girl? It should be low. Why is it high? We call this gonadotropin dependent. In other words, it is dependent upon FSH. It is also called true precocious puberty because it is the same mechanism as normal puberty. It is called central because it is the CNS which is involved. This is 85% of precocious puberty, and the follicles are being stimulated by FSH. Why are the FSH high? Most of the time, 80%, it is, I don't know. What is a medical term for I don't know? Idiopathic. Age is usually 6 to 7 years of age. This is premature activation of a normal hypothalamic pituitary ovarian axis. Why does it happen? I don't know. We do an MRI. There's normal findings. There's no CNS pathology. Physical exam is normal. So we just say it's idiopathic. So what do you do for treatment? The big concern is if you have high estrogens before they should, the short stature will develop, the bones, the epiphyses will close. And so we want to use GnRH agonist suppression. Leuprolide will suppress the FSH. And this is usually managed by a pediatric endocrinologist until the height becomes a certain point, until the development is at a certain maturity or whatever. I'm not sure what all the criteria are. But idiopathic, the most common cause, gonadotropin dependent, we use GnRH agonist. Now, you could have a CNS pathology. Usually we have a younger girl here. I'll show you some pictures. This is a CNS lesion, which somehow stimulates the hypothalamic pituitary ovarian axis to stimulate the GnRH. It may be a tumor. It may be a sarcoid. It could be an infection. It could be hydrocephalus, whatever. But this is where a head MRI would become very helpful. The treatment is then individualized based upon what the neurosurgeon or the neurologist, the pediatric neurologist would go with. But by far, this is a majority of precocious puberty, gonadotropin dependent, central. What if FSH levels are normal, low, which they should be? in precocious puberty or in prepubertal growth. So what would stimulate the ovaries to produce estrogens? We call this gonadotropin independent. In contradistinction to true, it is false. Instead of central, we call it pseudo. So you may see it is called false precocious puberty or pseudo precocious puberty because FSH levels are normal. A granulosa cell tumor can produce estrogen. The age is variable, and as you know, a tumor produces the hormone without any control. There's no feedback. The diagnosis is an imaging study of the pelvis, a sonogram, a CT. If you find a pelvic mass, surgical excision. Take it out. The other is McCune-Albright syndrome. This is a rare syndrome. It is also known as polyostotic fibrous dysplasia. There is often fibrous tissue which replaces the trabecular bone, and so you can have bone fractures. Pediatric orthopedists may see these girls. But the big thing to remember is that they can have autonomous production of estrogen by the ovaries. There can be also autonomous production of corticosteroids. I mean, there's a lot of different hormones. But if it is autonomous production of estrogen by the ovaries, you have this increase in the estrogen, but normal FSH. Diagnosis. Cafe au lait skin spots. I'll show you pictures of that. And the bone cysts because of the fibrous dysplasia. What do you do here? Remember, it is the aromatase enzyme that converts the androgens to the estrogens. So if you give an aromatase inhibitor, such as letrozole, such as tamoxifen, you can also prevent the premature closure of the distal epiphysis. This is in your book, and it shows what is the sequence of pubertal development and the age. And you should know this. Breast or thelarchy, pubarchy, adrenarchy, growth spurt. So by the time there is breast development and pubic hair, the growth spurt has already occurred. And here you can see menstruation is somewhere around 12 and a half. So the diagnosis of precocious puberty is female secondary sex characteristics with accelerated growth, less than 8 years of age in girls. The normal pubertal landmarks, initially we have breast development, thelarchy. That requires estrogen, age 9 to 10. Then it is followed by adrenarchy, pubic and axillary hair, age 10 to 11. Growth, the maximal growth spurt occurs 11 to 12, and then the first menstrual period, the first menarche, is age 12 to 13. Now, what I would like to direct your attention to is by the time she has had her first period, she has already reached the maximal growth. So if you're going to prevent the premature closure of the epiphyses, you really need to get at it early, or you may miss the opportunity and they will close. This, what I just showed you, is in your book on page 239. Here you can see the changes in the age of menarche. This was in 1840 in Norway and Finland. And what's happened, and they've kept very good medical records back here. It goes lower and lower until today we are about 12 and a half. When you look at this girl and her body, what would you say would be her age? I mean, she looks like a teenager, right? She looks like a teenager. She's 7 years old. See, boys are attracted by visual stimuli. And when they see her, they start moving in. What does she know about sexuality? See, these girls are high risk for victimization. High risk for victimization. Here is a CNS lesion, more likely, and here you can see the breast development in this 4-year-old girl. This is your granulosa cell tumor, and notice they call this precocious pseudo-puberty because the FSH is normal low. This is the cafe au lait skin spots that you may find with McEwen-Albright syndrome. And here is the cafe au lait spots as well. So this is something that you could look for on a physical exam. So the idiopathic, or sometimes called constitutional, is precocious complete isosexual means in the direction expected by the gender, so in the female direction. Heterosexual would be if you had a girl who was developing masculinization. So precocious complete isosexual puberty, 6-year-old girl, normal head MRI, most likely idiopathic or constitutional. Abnormal head MRI is usually a younger girl and a CNS lesion. McEwen-Albright syndrome, if you'd remember, cafe au lait skin lesions. Granulosa cell tumor, pelvic mass. Once you take out the pelvic mass, the hormone levels should go down very rapidly. Early puberty, put kids at risk, victimization. This is the youngest mother, youngest female who was a mother ever reported. This is the doctor who reported the case, and there's every reason to believe him. Peruvian 5-year-old Lena Medina, and here she is, 5 years old, accompanied by her 11-month-old son, right here. I mean, it's amazing. How old was she when she was pregnant then, and who was the father? This was in the British press. Baby-faced boy Alfie, who is supposed to be the father of this little baby here. I mean, he doesn't look old enough to get an erection. This is the girl he supposedly had sex with, but when they researched it, maybe there was some hanky-panky going on. Okay, Costumel. All right, let's take our break. See you in 10 minutes. Okay, this is our third hour, and we are going to talk about premenstrual syndrome, page 241. Does this look familiar? Does this look familiar? This is an old remedy, Carter's Little Liver Pills, showing the two different women. Whoever wrote this or made this license plate really didn't know what they were talking about. Because if the symptoms are 24/7, it's not PMS. Because PMS comes and it goes. It comes and it goes. It's not there all the time. Okay, here is our case. 30. This is not symptoms with the menses. They actually go away when the menses start. This is pre-menstrual. I suppose every ovulating woman has symptoms, but when they become to where they interfere with your life, we can call it premenstrual syndrome. This is the term that gynecologists, non-psychiatrists, the psychiatrists would use the term premenstrual euphoric, PMD, and this is in your book. All right, let's look at our handout. The first thing you should know is that you should have the patient keep a symptom diary. What are the symptoms that she has? Grade them from 0 to 4. Where do they occur on her menstrual cycle? And you'd like to keep this through 3 menstrual cycles. The importance of the diary is that the symptoms are less important than when they occur. They should occur only in the last half of the cycle, not week 1. So pre-ovulatory should be symptom-free. They should occur in 3 or more consecutive cycles, and they are severe enough to require treatment. Then you look for, is there any particular symptom cluster which seems to predominate? And I'll look at these in just a minute, such as emotional, fluid retention, autonomic, musculoskeletal. There have been all kinds of treatments suggested, generic treatments, lifestyle, relaxation, make sure you get good exercise, support group. A support group is somebody who is experiencing what you are experiencing. You don't need to explain it. They know right away, and they can be really helpful to you. Now, all of these would be good for any of us to relax and exercise, support groups, maybe less caffeine, sugar, and salt. These would be called generic treatments, hardly specific. The specific treatments are here. Now, the first treatments which were used were vaginal progesterone suppositories. Did they work? Yes, they did, but so did the placebo. So there's a strong placebo effect that you need to be aware of. So you really need to do double-blind studies on this, where the patient doesn't know what they're getting, neither does the researcher. Spironolactone is a potassium-sparing diuretic that may help if you have mainly fluid retention issues. Vitamin B6 is supposed to be good for depression. The only medications which have been approved by the Food and Drug Administration are SSRIs, and we'll talk about those in a minute, and Yaz, which is the drospirenone oral contraceptive, which is 24 days on and 4 days off, if you remember that from yesterday. Okay, keep us a diary of 3 cycles, and the symptoms need to be not only recurrent cycle, they should start by ovulation, but when the menses come, they should be gone. And they should be severe enough to function. And the symptoms are less important than the timing. That is really critical. This is in your book, page 241, just what I said. All right, when you look at the menstrual cycle, here's a 21-day cycle, week 1, 2, and 3. Here's the 28-day cycle, 1, 2, 3, 4, and so on. You'll notice it is the post-ovulatory phase where the symptoms should be present. So there should be at least a 7-day symptom-free period, or it could be up to 21 days, depending on the length of the cycle. Lots of possible explanations. Ovarian steroid fluctuations, CNS neurotransmitters, genetic predisposition. There are a lot of different, and I suspect in a few years, when we understand what's going on, we will say, wow, how could we have been so foolish? Okay, this is your PMS diary. This has the week of the cycle right here. And then you will show when the menses occur. This looks at the symptoms, 0, 1, 2, and 3. That would really be helpful. So on the exam, that's really what you need to start with to make a diagnosis. Okay, what are the symptoms? It could be breast tenderness, extremity edema, weight gain, and bloating. These seem to be more fluid retention. Autonomic nervous system, heart pounding, confusion, dizziness, insomnia, fatigue, emotional, nervous tension, mood swings, depression, irritability, anxiety, and crying, musculoskeletal, muscle aches, joint aches, headaches, cramps. It's hard to put your finger on. It's 5 out of 10 criteria. Chronic fatigue syndrome. I don't think we don't understand this stuff very well yet. All right, treatment, we talked about diet, we talked about lifestyle. The medications, these are not recommended, although they may work for some patients. It is SSRIs. Fluoxetine was the first one that was used, and the oral contraceptive is the specific drospirenone with a 24/4 distribution. The placebo effect is when you think it's going to help, it does help. There's also what is called a nocebo, where if you think it's going to make it worse, even though it is just salt on a saline, it may make it worse. The opposite of the placebo effect. And when you think of voodoo and how people are told you're going to die, and they do die, that's a very strong nocebo effect. All right, the pharmacological treatment, fluoxetine was some of the first medications used, sertraline and some of these other ones as well. The important thing here is you don't need to give it continually. If the patient knows symptoms will come 2 days before, so you get around the potential libido suppression, which can occur on continuous SSRIs. She used to be out of control, and now she is in control. The trade name is Sarafem. Sara, serotonin, fem, female. It's really just another trade name for fluoxetine. Wash your blues away. Okay, this is the Yaz, drospirenone, FDA approved for PMS. You should know that. 24 on, 4 days off. And this is the cave in Cozumel. Okay, hirsutism. Actually, I don't like that term, hirsutism. A better term would be male pattern hair in a female. Male pattern hair. Here's our case. A 28-year-old patient complains of increasing hair growth on her face and chest for the past 10 years. Men can have growth of hair on their chest and face. That's normal, but that's not where women usually have it. Her menses are irregular and unpredictable. She's been married for 8 years without contraception, has never been pregnant. Sounds like there could be an infertility issue. On pelvic exam, the ovaries bilaterally are slightly enlarged. What do you think this is going on? What is this consistent with? It sounds like PCOS, doesn't it? We'll go over that a little more detail later on. But let's look generically at hirsutism. There's a scoring chart that you can use. You can actually grade 1, 2, 3, 4 on the upper lip, on the chin, on the anterior chest, on the anterior abdomen, on the pubic area. It's interesting, it is on the proximal upper extremities, the arm, not the forearm, and it's on the thigh, not on the leg, where the androgen effect takes place. On the back, on the buttocks. So, pains per weight. This is a woman. This is a woman. Now, does she have female body contours? Yes, she's got breasts, but she's got male pattern hair, but she hasn't lost the female characteristics. Can you see the hair on this woman's breast, on her chin, on her lip here? And yet this woman had normal peripheral androgens. She did not have elevated androgens. So we can talk about hirsutism as excess male pattern hair in a female who looks like a female. But virilism is where you have masculinizing signs. It doesn't look like a woman anymore. It looks like a man. Now, this is hirsutism. If you could just subtract visually the hair away, it still looks like a woman. But how about this? This looks like a man. You have enlargement of the clitoris, clitoromegaly, you have frontal balding, you have loss of female body contours. Now, is this a man or a woman? This is actually a woman. This is what she used to look like. And this is what she looked like. She was a cyclist and a competitive cyclist, and she took male hormones, and look at what happened to her body. High levels of peripheral androgens will masculinize. Male or female. This is a female. Male or female. This is a female. 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 Oh, this guy. Well, forget him. What is it that brings about the conversion of the thin, fine, delicate hair on a female's face and makes it into terminal hair, the dark, heavy hair on a man's beard? And what it is androgens. It's androgens from the ovary, from the adrenal gland, from the hair follicle. That's what stimulates it. See, it's the androgens which leads from this villus hair to the terminal hair. It's the androgens acting on the hair follicle. So this is a normal female hair distribution. You see, if there is hair on the lower extremities, it's on the distal legs, on the distal upper extremities. Now this is looking at androgens, 5 different androgens and their relative potency. This is dihydroepiandrosterone sulfate, produced entirely by the adrenals. This is dihydroepiandrosterone. This is a relative potency of 3, so it's 3 times more than this. Androstenedione is 10 times. but testosterone is 100 times more than DHEAS, and the most potent androgen is dihydrotestosterone. Now, DHEAS, DHEA is produced by the adrenal. Androstenedione and testosterone can be produced by the ovary. But dihydrotestosterone is a conversion of androstenedione and testosterone into the DHT in the ovary, or I should say in the hair follicle. And it's 5-alpha reductase enzyme that does that. So our lab workup will look at DHEAS levels, which is produced by the adrenal, 17-hydroxyprogesterone, which is produced by the adrenal, testosterone from the ovary. And if all of these are normal, we will assume that it is DHT, which is elevated. But this is not found in the peripheral circulation. It's found in the hair follicle. So you really can't measure it. So it's really more a diagnosis of exclusion. Okay, let's look at our handout. We want to get DHEAS, testosterone, and 17-hydroxyprogesterone levels. If those are normal, we will assume it is because of DHT from the hair follicle. All right, on physical exam, is there virilization or hirsutism? If there is virilization, loss of female contours, masculinization, in the presence of rapid onset and a family history which is negative, if you get very high levels of DHEAS, that is from an adrenal tumor. How do you find if there is an adrenal tumor? CT imaging of the flank. If you find a tumor, surgically take it out. Also, if there are very, very high levels of testosterone, which would suggest an ovarian tumor, then the diagnosis is made by imaging, and you can do a sonogram of the pelvis. And if you find it, surgical resection. So this is virilization. Rapid onset, typically family history is negative. Very high levels of peripheral androgens. All right, let's look now at hirsutism. And hirsutism is gradual onset, not rapid onset. Gradual onset, and family history is often positive. So what would we find on our laboratory tests? We would find mildly elevated testosterone, PCO syndrome, PCOS. We'll talk about that in just a minute. So what do you do for that? The diagnosis is made looking at the ring of Pearl's follicles around the ovary, PCOS, and LHFS ratio. Treatment, we'll talk about this coming up shortly, will be estrogen plus progestin oral contraceptives. What if you have an elevated 17-hydroxyprogesterone? This is because of congenital adrenal hyperplasia. This is where you have an enzymatic deficit. In this case, the enzyme is 21-hydroxylase deficiency, and it prevents going on to form the corticosteroids, and you have the 17-hydroxyprogesterone, which continues down the androgenic pathway to make androgens. So what do? The only thing you can do is a lab test and give corticosteroids to feed back to the anterior pituitary to lower the ACTH, which is driving up the 17-hydroxyprogesterone. What if testosterone is normal, 17-hydroxyprogesterone is normal, DHEAS is make a presumptive diagnosis of elevated DHT in the hair follicle. Idiopathic, but it's not really idiopathic because we know what causes this. This is a too high functioning of 5-alpha reductase enzyme. So what do? We use a 5-alpha reductase enzyme inhibitor. Now, finasteride is used in men to prevent men from going bald, but we don't want to use that in women because of the concern about teratogenesis. So we use a potassium-sparing diuretic, spironolactone, which has as a side effect 5-alpha reductase enzyme inhibitor. This is in your book. On page 246. And it shows that ACTH drives the adrenal to make progesterone, which is converted to 17-hydroxyprogesterone, which goes to produce cortisol. But see, if there is a deficit of this enzyme right here, 17-hydroxyprogesterone, what happens? Instead of this going to make cortisol, it is driven down in this direction, and we end up with testosterone and dihydrotestosterone. So the idea is we want to give cortisol that will feed back to the ACTH and will lower it so you take away the driver of the increasing 17-hydroxyprogesterone. This is a structural formula for finasteride. Trade name Propecia Proscar. And Cozumel. Okay, PCOS, Polycystic Ovarian Syndrome. Here's our case. 32-year-old woman complains of vaginal bleeding, facial hair growth, and obesity. So it's vaginal bleeding, hirsutism, and obesity. The facial hair growth has been present for many years. If you've got something which is present for many years, what's the likelihood of it being a tumor? Very, very minimal. Because with a tumor, you'd expect to have high levels, and you have masculinization. So this is not probably a tumor. The irregular bleeding has been getting worse during the past 6 months. Probably she's got anovulation. On pelvic exam, she has slightly enlarged bilateral ovaries. That's consistent with PCOS. Now, have you heard of Heron syndrome? H-A-I-R-A-N. Heron syndrome is a multi-system challenge. It is an acronym for an unusual multi-system disorder in women that consists of HA, hyperandrogenism, IR, insulin resistance, and AN, acanthosis nigricans. The precipitating abnormality is thought to be insulin resistance. So it is HA, hyperandrogenism, IR, insulin resistance, AN, acanthosis nigricans. The internists used to ignore PCOS and say this is a gynecologic problem which results in hair and infertility, but you can take care of that just fine. But now that we recognize that a lot of these women have insulin resistance, which leads to type 2 diabetes, which leads to obesity, which leads to cardiac disease, which leads to vascular disease, now we've got a lot of interest. This is sometimes called metabolic syndrome or syndrome X. Insulin resistance leads to hyperandrogenism because insulin increases testosterone production by the theca cells, and it also leads to acanthosis nigricans, which you can see by physical exam. My wife and I were in the airport flying someplace and waiting for the plane, and I said to my wife, "You see that woman over there? She's got polycystic ovaries." And my wife looked at me and said, "How do you know what her ovaries are like?" Well, if you see acanthosis nigricans, that's a pretty good marker. Okay, PCOS. It can be defined as a condition of chronic anovulation resulting in infertility, irregular bleeding, obesity, and hirsutism. We've talked about a number of these already. It's interesting. The Endocrine Society this year, well, actually last year, defined PCOS as the presence of any 2 out of the following 3: androgen excess, hirsutism, ovulatory dysfunction, anovulation, or sono visualization of polycystic ovaries. There's a lot of different people, a lot of different organizations who have tried to define the criteria for PCOS. But I think if you use this here, you'll be pretty safe. All right. I showed you this picture before. Large ovaries. Large ovaries. Can you see how they hang down behind the uterus? They're not off to the side, like on the picture that I had. What makes them large? It is these follicles, which are in a atretic, frozen situation. They don't progress on and they don't involute. And it is because of the testosterone levels, which are high, which stop these ovaries from maturing. I should say it stops the follicles for maturing. Okay, let's look at our handout. And this I've given you, it's got 4 of these, and I'm going to go through them. They're pretty detailed, but I think you will see and you'll be able to understand and work your way through. All right, the diagnosis of PCO. Suspected on the basis of infertility, irregular bleeding, obesity, and hirsutism. Okay, we already talked about that. That's the clinical findings. The laboratory test that we look for is the LH-FSH ratio, and it is elevated LH. It should be normal 1.5 to 1 rather than 3 to 1. Now, what does LH do? LH stimulates what cells in the ovary? It is the theca cells. And what do the theca cells produce? What hormone? Androgen. That's where the androgens rise because we have an increased LH. All right. When you have a steady state FSH, so it's not low, but it's steady, you're going to have steady state estrogen. If you don't have a rising estrogen, you won't have an LH surge. If you don't have an LH surge, you'll have chronic anovulation. If you have chronic anovulation, you don't have any eggs and you have infertility. The treatment for that, clomiphene. We talked about that. Interestingly, you can also use metformin, which increases the sensitivity to insulin. And some women will ovulate in response to that. If there's no LH surge, there's no corpus luteum. If there's no corpus luteum, there is no progesterone. If there's no progesterone, you have unopposed estrogen, which can lead to anovulation, hyperplasia, irregular bleeding. And what do we do for irregular bleeding? Progestin, we talked about that, MPA, or we could use combination estrogen, progestin, oral contraceptive pill. All right, the increased testosterone. The increased LH-FSH ratio increases the steady state level of LH. LH and insulin stimulate the theca cells to produce increased androgens. So we have increasing free testosterone because of the increased production of androgens by the theca cells. Now, when you have elevated androgens, you have decreased liver synthesis of sex hormone binding globulin. If you have less of the sex hormone binding globulin, you have a higher free androgens. So both of these, the steady state LH and the high androgens, stimulate high free testosterone. And of course, that's what is the active agent, hirsutism. We talked about the best treatment is oral contraceptives, and I'll show you why in just a minute. The oral contraceptives can, they have estrogen. And so they will decrease the production of androgens. The estrogens will also increase sex hormone binding globulin, so you'll have more binding and lower free testosterone. So, in summary, infertility, we can work with clomiphene or metformin. Irregular bleeding, we can use progestins, MPA, but we could also use oral contraceptive pills. But she really doesn't need the estrogen, right? But for the hirsutism, she does need the estrogen because the estrogen will suppress the LH and the production of androgens. So that's why I would say better to give oral contraceptives generically for PCOS. And we talked about spironolactone. Metformin is as good as clomiphene. No increase in birth defects with metformin. So if we use metformin to induce ovulation, we will continue that through the pregnancy. This is interesting. A new study, letrozole, an aromatase inhibitor, may also help in ovulation induction, but that's not in current use yet. Okay, the next topic will be infertility. Is this a big problem? What percentage of couples in the US have infertility? 15 to 20%. That's high. That's very high. Here's our case. 35-year-old patient complains of infertility for 1 year. The criteria for infertility is in the presence of timed mid-cycle intercourse, no pregnancy after 12 months. So they certainly meet the criteria for infertility. Patient and her husband are unsuccessful getting pregnant, no history of PID, tubal factor is a concern. She used oral contraceptives for 6 years. Could she be anovulatory? Pelvic exam is normal. All right, let's see, where do we go with this? This is a big problem. He can't get her pregnant, so he feels a failure. She can't give him a baby, so she feels a failure. Big problem. When you look at the causes, male and female are about the same. Combined is about the same. So you can't say it is a male or a female issue. It's really a couple problem. They both need to go for the workup. So let's look at our handout. We already said this. Infertility can be defined as no pregnancy with 12 months of unprotected mid-cycle intercourse. It's important to take a history. What if a couple have sex only once every couple of months and they're not getting pregnant? Well, that would certainly explain that. All right, where do we go now? Next, we'll do the initial non-invasive tests. These are tests which can be done in the office. Ovarian reserve, we're going to look at if a woman is 35 or greater. Ovarian reserve says how sensitive are the follicles which are left in her ovary to FSH. Because if she has resistant follicles, that's going to make it very difficult. And so what you do is you get a FSH level on day 3. And the lower the FSH, the more ovarian reserve. The higher the FSH, the lower is the reserve. Because she needs to push on the gas pedal more in order to try to get a follicle to pop. Okay, next we're going to look at male factor. Semen analysis, that could be done as an outpatient. Is the semen analysis okay? And largely we look at sperm concentration. The lower limits of normal is 20 million per milliliter. If we have minimally abnormal, let's say a 10 million sperm concentration, then we can go to IUI, which is intrauterine insemination. If it is severely abnormal, let's say we only have 10 or 20 sperm, then we go to ICSI, intracytoplasmic sperm injection. This is all defined down here. If there are no viable sperm, then we go to artificial insemination by donor. Okay, this is simplifying it, but I think it's all you need for the exam. What do we do for office evaluation of the woman? Is she ovulating? And we've looked at this many ways. History, irregular bleeding without any cramping. Basal body temperature stays flat, does not rise at mid-cycle. Serum progesterone is low. Remember, progesterone is made by 2 places, the placenta and the corpus luteum. So if a woman isn't pregnant and if she's not ovulating, she will have a low progesterone. The treatment, we talked about this, is clomiphene citrate, feeds back to the anterior pituitary, says we need more estrogen, give us FSH. As the FSH levels rise, estrogen rises, that stimulates the LH surge, and now you have ovulation. If that doesn't work, you may need to use HMG. HMG is human menopausal gonadotropin. The risk always needs to be remembered for multiple gestation. 10% risk of multiple gestation with clomiphene, although I've seen quadruplets with clomiphene. And using human menopausal gonadotropin, you have up to 30 to 40% multiple gestation. Okay, male factor, semen is okay. Ovulation, no problem. Now where do we go? All right, follow-up invasive test. And the follow-up invasive test is hysterosalpingogram looking for tubal disease. So what are the three main causes of infertility? Number one, male factor. Number two, anovulation. Number three, tubal disease. The hysterosalpingogram. Why do you do that? Because you want to see, is the tube normal or abnormal? If it is abnormal, we need to do a laparoscopy to either repair the damaged tube or remove them and go to IVF. If we go to IVF, then we need to do the salpingectomy, take out the damaged tubes, and you actually have a higher rate of success if you take out the tubes. In vitro fertilization will then be the next step. All right, let's say the tubes are okay. Male factor, no problem. Anovulation, no problem. Tubal disease, no problem. We call that unexplained. No problem with 1, 2, or 3. Now where do we go? Then we go over here and we go ahead and do intrauterine insemination anyway. We do ovarian hyperstimulation anyway with clomiphene or HMG. And then we see, does it work? Does it work? If it doesn't, if it fails, then that's another indication for in vitro fertilization. So the three indications for in vitro fertilization are up here, severely abnormal semen analysis. We need to do ICSI, intracytoplasmic sperm injection. Number two, the oviducts are green and ovarian hyperstimulation. So now we do in vitro fertilization. And in vitro fertilization involves ovarian hyperstimulation. You want to get lots of follicles. Then you need to do egg retrieval. Then you either do in vitro fertilization where you mix the sperm and the eggs, or you inject one sperm into the egg. That's ICSI. And then you transfer the embryo in day 3 to 5. The later you can do it, the less likely you will have to have multiple gestation. Okay, fertility. Infertility, we talked about this. No pregnancy with regular sex for 12 months. Fecundity is a percentage of conceptions with 1 month of unprotected sex. And this looks at the fecundity rate. At age 20, the likelihood of conceiving in 1 month is 20%. Age 30, 15%. At age 30, can you see what's happening over time? Fecundity is a function of the age of the female partner. And here you see the likelihood of conception occurring. After 1.5 months, 25% of couples should be pregnant. After 3 months, it's 50%. After 6 months, it's 75%. After a year, it should be 90%. Once you get that high, then you say, maybe we need some help. When does the decline occur? What age does it occur? Is it here? Is it here? You pick the point, but you can see the line is dropping down. Fertility decreases with age. How many women would love to stop the clock? How many would like to just flip the switch and let the videos, let the eggs stay there? But that's not going to happen. Now, you could do oocyte cryopreservation where you actually freeze the eggs, like you freeze the sperm. But it's fairly pricey, about $12,000 to $15,000 for that. Okay, the three causes: anovulation, male factor, tubal disease. We talked about semen analysis. This is a normal sperm. What's this? Hydrocephalic. What's this? Microcephalic. It's interesting, up to 15 to 30% of normal men can have abnormal sperm and yet be fertile. Now, when you look at the lower limits of normal of semen concentration, sperm concentration, is 20 million. This is a man who brought in weekly semen specimens for over 120 weeks, dedicated to science. What was going on here? What was going on here? He is okay. So there can be fluctuation. So the next step in management, if you have a low sperm concentration, is repeat the semen analysis. The spermiogenesis cycle is 74 days. Now, intrauterine insemination, you put the sperm directly into the uterus, you bypass the cervical mucus where many of these are taken out. So here's the sperm, here's the eggs, and you give them a help on their way and hope that they will have a date right about there. ICSI, intracytoplasmic sperm injection. You're going to pick this guy or this one or this one. This is what the embryologist has to do. And they pick one sperm and they inject it into the egg. One sperm. And that's going to be a pretty significant decision. Now, they do have criteria on which to assess that. Now, you can do pre-implantation diagnosis on the morula by taking out one of these at the time in IVF. Okay, we talked about semen analysis. You want to avoid intercourse for 2 to 3 days, so you build up the sperm. If you have an abnormal, repeat it. If it's minimally abnormal, IUI. Severely abnormal, ICSI, no sperm, AID. And ovulation, clomiphene, this is the oral tablets. If that doesn't work, then you need to inject with human menopausic gonadotropin or Pergonal. Follow-up tests, hysterosalpingogram. If we have potentially correctable tubal disease, let's fix it. We call that a tuboplasty. Or remove it. Remove the tubes and do IVF. These tubes are not going to work very well. You may want to take those out. Unexplained infertility, clomiphene anyway, IUI anyway. Then IVF. We talked about the 3 indications: oligozoospermia, no sperm or very low sperm, to where you have to do ICSI. Irreparable tubes, you can't fix the tubes, or unexplained infertility. So you retrieve the eggs, in vitro fertilization, incubate for 3 to 5 days, embryo transfer. It's probably $15,000 a cycle. So that's a fair chunk. Okay. Lots of studies. Ovarian reserve, we already talked about that. You see, here's what happens. A woman's own eggs, she is reasonably successful in IVF up to what age? You can see her own fertilization rate is going to go down probably around age 35. And this can be assessed using the ovarian reserve. And this is why over age 35, if you do IVF, you may need to use donor eggs. Okay, let's take our last break, and then we will finish menopause, and then we will go to female breast, and then we'll have some questions, and then we'll be through for the evening, actually through for the course. So let's take a 10-minute break. Okay, and so we begin our last hour. We're going to finish this chapter. The last part is menopause, and then we will go to uh, the female breast, and that should finish it. All right, menopause. Here's our case. A 53-year-old woman complains of hot flashes, vaginal dryness, and irritability. Vasomotor symptoms. Her symptoms started a year ago, getting worse. Her last gynecologic exam was 2 years ago. Mammogram was normal. 53 is right about where we would expect for menopause. When you look at the average lifespan, life expectancy from 1850 to 2000, and that is the purple line here. You can see that prior to 1900, the average woman didn't live long enough to experience menopause. But after, we can see there's a gradual rise. And nowadays, what percentage of your life, ladies, is going to be postmenopausal? And it looks like about a third. So this is a big concern. Is this going to be a happy time? Is it going to be an unhappy time? What are the issues we need to look at? When you look at the number of oogonia in the ovaries, the highest number is at 20 weeks gestation in the middle of the pregnancy, ladies, when you were in your moms. And then from age 20 weeks until birth, there was a rapid drop from 6.5 million to 1.5 million at birth. And then that declined gradually, about 1,000 every month, until at the time of puberty, there may be 300,000 to 400,000 left. And those are gradually being atrophied by 1,000 a month just from, what's the word I'm looking for? Apoptosis. It is planned cell death. You really can't joke. You can have it a couple of years earlier. But by delaying ovulation, being on oral contraceptives, or having pregnancy, you'd think that you wouldn't lose as many follicles. That's not true. So when they are all gone, that's what we call menopause. Age 40 to 60 is the range. Mean is 51 years of age. Menopause, the diagnosis is laboratory is serially elevated FSH for 3 months. We talked about if you have low estrogen, how would you find that out? By doing an FSH, which is high. Now, the clinical findings for menopause is 12 months of amenorrhea. The etiology is lack of follicles. Maybe it should better be said lack of functional follicles. Amenorrhea is the most common complaint, but not all women will have hot flashes. Why not? Because if they are obese, they are producing peripheral estrone, and that takes care of the hot flashes. When you look at effects of estrogen deficiency, there are the early effects: hot flashes, sweating, insomnia, menstrual irregularities. Now, no one's going to die from these. Then there are the intermediate, the vaginal atrophy, dyspareunia, urgent stress, incontinence. These also are not going to kill anybody. But when you look at the later ones, osteoporosis fractures, coronary heart disease, cardiovascular disease, Alzheimer's, these now become big issues as you get over 60. Estrogen receptors are everywhere: brain, heart, blood vessels, bones, skin, vagina, breasts, everywhere. Our particular interest is in the reproductive tract, the urinary tract. Now, psychologically, we've got the effect on the brain and the vasomotor symptoms. Now, when you ask women, what are you afraid of dying from? Most women will say breast cancer. But most women will die from cardiovascular disease. That's the most common cause of death. So that's something we need to look at. An osteoporosis, decreased trabecular bone density, that's another issue. I think we're going to have to leave the internal medicine people to talk about that. I don't think we have enough time. I wish we did. Normal bone, trabecular bone. Maybe we'll stop here for just a moment. Notice the highest bone density is around age 30 for both men and women. And then we see a decline, which starts and continues on. Men will always have a higher bone density than women. You see, women, the fracture threshold is right here. Women could have osteoporotic fractures as early as age 60. Whereas for men, it's not typically until age 80 or greater. So what you want to do is to get your bone density as high as possible and then keep it from going down as much as possible. So high maximum bone density and then slowest loss. And I wish we had time to talk about this. This is in your notes, and we're going to just have to leave it at that. Okay, my interest right now is cardiovascular disease. If you look at why women die, this is breast cancer. This is cardiovascular disease. The big issue is cardiovascular disease. And this is a big issue in hormone replacement therapy. We used to give estrogen to every woman. And now we look at and we say, maybe we don't need to. The observational studies of cardiovascular disease and hormone use suggested there was a great benefit. This is a nurse's health study. When we look at the HERS study, where women who already had cardiovascular disease and they got estrogen, they actually did worse. So there's not any good evidence that there is any benefit in secondary prevention. The question is it good for primary prevention? The prospective studies of primary prevention, of which one of the largest was the Women's Health Initiative. What that study suggested was that it was not good, that there was a 100% increase in blood clots, increase in strokes, 40%, heart attacks, and so on. There was a benefit with estrogen and progestin, less colorectal cancer, hip fractures. What I want you to notice is this was estrogen plus progestin. Estrogen plus progestin. I'll come back to that in just a little bit. So many women went off estrogen because of the concern of this study. This is on page 253 in your book. And what I want to look at is what actually did it show. And you see we have two columns. Women with estrogen plus progestin and estrogen with only estrogen. These are women who had a hysterectomy. And what you see is both groups benefited from vaginal dryness, hot flashes, they were better, vasomotor symptoms were better, and osteoporosis was better. So both groups benefited. When you look at breast cancer risk, it was not in the estrogen only. There was no change. It was only in the estrogen plus progestin. Heart disease, there was no change in the estrogen only in the estrogen progestin. Stroke, there was an increased risk in both of these. But what would this suggest to you? Is the problem estrogen or is it progestin? And the evidence would suggest it is a progestin. For the exam, you should know the only indication for estrogen hormone therapy is vaginal dryness, hot flashes, and vasomotor symptoms. Even though there's a benefit in terms of osteoporosis, it is not recommended as the first line treatment. The evidence suggests that when you reanalyze the Women's Health Initiative, the timing of the starting of estrogen replacement may be the key to success. In other words, you need to start it right after or at menopause, not later on. So what I'm going to share with you now, and which is in your notes, is the global consensus statement on menopausal hormone therapy. So let's go through this. And I've given you this handout that looks like this, and I'm going to go through these. The proven benefits of menopausal hormone therapy. Vaginal or vasomotor symptoms. There's no question it is the most effective treatment. Vaginal dryness. It is excellent for that. Premature menopause. If you take out the ovaries of a woman, a TAH BSO who is premenopausal, she needs to have replacement. So these are the indications for menopausal hormone therapy: vasomotor symptoms, vaginal dryness, premature menopause. Now, and this is in your book on page 253. When you look at what are the concerns, osteoporosis, there is a clear benefit, but because it does have the other concerns in regarding the stroke, the first choice for osteoporosis is the bisphosphonates and the selective estrogen receptor modulators. So alendronate and raloxifene, even though estrogen is effective. The most benefit is age less than 60, and if started within 10 years of menopause. So this is a benefit, but it is not your first choice medication. This is in your book. Okay. Coronary heart disease prevention. This is important. It is a benefit, but it is not an indication for use. Estrogen only decreases coronary heart disease and all-cause mortality. These are women who had a hysterectomy, take only estrogen. The most benefit is less than 60 years of age and within 10 years of menopause. When you add the progestin, there is no effect on preventing coronary heart disease. So it decreases the beneficial effect of estrogen, but it may decrease all-cause mortality. But if you have a uterus, you need to give progestin to prevent unopposed estrogen and estrogen or hyperplasia and even carcinoma. Early estrogen, protective, decreases cardiovascular disease. Late estrogen, harmful. It ruptures the plaques and can increase cardiovascular disease and strokes. So if you're going to give it early. Progestin has a negative effect. It decreases the protective effect on patients who have the cardiovascular disease. So estrogen would be ideal. Can we get away with not giving it progestin? If they have a uterus, they need to have it. Let me have that. I think that's coming up next year. Okay, early start of estrogen will decrease cardiovascular disease. Late start will release the plaques and will increase cardiovascular disease. So the benefit is really only for the younger women. Strokes, the absolute risk is low, but that is a risk. The lowest risk is with transdermal. Because that avoids going through the liver and stimulating clotting factors. Breast cancer, the absolute risk is low and is only associated with progestins. And the only progestin is the MPA. It is related to the duration of use and should not be used in breast cancer survivors. So that's the importance with the breast cancer and the venous thromboembolism. Interestingly, estrogen-only hormone therapy lowers the risk of breast cancer. Okay, if a uterus is present or absent, estrogen therapy only. If the uterus is absent, you must give estrogen plus progestin if the uterus is present. We've talked about that many times. You individualize the dose, you individualize the duration, you individualize with the patient. Bioidentical hormones, these are custom compounded in pharmacies, are not recommended. There is no supervision by the FDA. You can't be sure what you're getting. So bioidentical hormones, not recommended. Okay. Early onset of estrogen, I'm kind of repeating myself here, is protective. Delayed onset is harmful. Progestins, they offset the protective effect. And I think that's all. Where is this? Where am I where this picture is taken? San Francisco, Alcatraz. This is the famous Alcatraz Island. Okay, let's go on to the last chapter, which is chapter 13, the female breast. Okay, I know who writes the questions for the OBGYN on the step 2 exam, and that is OBGYNs. Who do you think writes the questions for breast disease? And I think it is probably going to be the surgeons. So you do whatever the surgeons say, and if what I say is different than the surgeon, then you better go with the surgeons. But let me just go over what we've got, and hopefully I will concur with the surgeons. All right, chapter 13. Okay, chapter 13. This is my swan song. This is Cygnus the swan. Cygnus the swan was a mythical bird that didn't make any sound while she was alive. But just before she died, she sang the most beautiful song you ever heard. And that's why when people are leaving, or they're dying, or they're going away, the last words that they will say are often called their swan song. So this is my swan song. And in half an hour, I'll be gone. Okay, let's look at breast disease. Some of these are pretty bad pictures. I don't see this much anymore, fortunately. Look at the skin metastasis. Lymphedema. Okay, first case. 40-year-old menstruating woman had a 2-centimeter cystic breast mass confirmed by breast ultrasonography. What do we do with this? It used to be that all of these breast masses were removed by open biopsy. But today, the cystic masses can be removed by fine needle aspiration. FNA is fine needle aspiration. You send it for cytology. If you do a mammogram and it comes back negative, if the cyst is gone, the cytology is negative, you're done. And 90% of breast masses can be aspirated through FNA, fine needle aspiration. Use some local anesthetic if you need to. Often the local anesthetic hurts more than putting the needle in, and you aspirate. This is your fine needle aspiration. Sometimes this is called fine needle aspiration, but it's really a core needle biopsy where you have a solid lump and you go in and out. Now, this is the vacuum mammotome. I'll show you a picture of this. This is done for microscopic calcifications, which you can't palpate. This is a large core biopsy, and this is your typical standard outpatient surgery open biopsy. We like to do as few of these as possible. Okay, what do you think about breast self-exams? Good idea or bad idea? It's interesting. There was a large study from mainland China where they looked at teaching 266,000 Chinese factory workers. Half of them were taught to do self-breast exam, half were told not to. They were to be followed for a period of 10 years. They broke the code in 5 years and found that there was no difference. There was no reduction in the invasive breast cancer by breast exams by the patient. So the American Cancer Society says self-breast exam is optional, not routine. Now, I think breast awareness is important. I think women should know what their breasts feel like. And monthly breast exams, I think, are not bad. But there is no evidence that it decreases the rate of invasive breast cancer. No evidence of that. Now, we talked about mammography before. There is good evidence that it can lower breast cancer rates. But there's a lot of controversy with mammography. We already looked at these pictures before. Did I have my mammogram today? Why did you ask? Well, mammograms are made by compressing the breast. And this is the manogram, not the mammogram. You know, the concern is, are we radiating the breast unnecessarily? And are we causing more cancer than we detect? And that's what the controversy is really all about. This is a no-brainer. You can see the mass here, different than over here. The idea of mammography is that you will pick up a breast cancer before you can palpate it. Now, this graph or figure is based upon the idea that we have right here a breast cancer cell which doubles in size every 100 days. It will take 6 years to where it will be 1 millimeter in size. So it's typically slow growing. You can't feel it, you can't palpate it, but you could see it on a mammogram. At 9 years, you will be able to palpate the lesion, which is 1 centimeter in size. So the idea is you can push up the diagnosis by mammography by 3 years. And obviously, the earlier you pick it up, the less will be the stage, and it won't have spread. That's the idea of mammography. So you want to pick it up here, not over here. Now, there's lots of organizations that make recommendations for mammography screening. What do you follow? This is American Cancer Society. This is American College of OBGYN, American Medical Association. This is United States Preventive Services Task Force. And you see, all with the exception of USPTSF, say mammogram age less than 35 if you have an increased risk, a first-degree relative who has breast cancer. Otherwise, a baseline between 35 and 40, and then do annual mammograms. And I think that's what I would answer on the exam. Annual mammograms starting at age 40. This is very interesting. This is the dollars spent per life year saved compared to the current policy. And here we are at age, this is our current policy. And this is if we extend mammography to age 74 and so on. And what they're looking at is if you screen every 2 years, not every 3 years, you pay a huge amount of extra money, but you really don't improve the outcome in terms of the patient. So it's controversial. Breast self-exam, option only starting age 20. Clinical breast exam, this is done by a physician, by a nurse practitioner, by a physician assistant, every 3 years, age 20 to 39, and then every year at age 40. And start mammograms age 40 annually as long as she's in good health. That's the American Cancer Society. Now, there is a lot of controversy about breast density. And you can see the difference in the density of these breasts. It is much harder to diagnose breast cancer in a dense breast. The relative risk of cancer, looking at breast density, you can see the denser the breast can go up to 5 times higher because it's harder to see. This is a website that says breast density is one of the strongest predictors of the failure of mammography to detect cancer. Are you dense? And actually, the California legislators have insisted that on the mammogram report, it not only says your mammogram is negative, but it says your mammogram shows that your breast tissue is dense. Dense breast tissue is common, is not abnormal, but it can make it harder to evaluate the risk of your mammogram. So the idea is to let patients know. Okay, fibrocystic changes. A 30-year-old woman experiences bilateral breast enlargement and tenderness, which fluctuates with her menstrual cycle. On exam, the breast is lumpy with a discrete 1.5 centimeter nodule, which is consistently painful. This used to be called fibrocystic breast disease. 50% of women have this. Do we say that 50% of women are diseased? So they changed the term to fibrocystic breast changes. It's very tough to know how to deal with this. If there was a good treatment, we'd know it. There's all kinds of treatments prescribed: oil of primrose, grandma snake oil, shaking the chicken bones, all kinds of stuff, bromocriptine. The main thing to remember is if there is a definitive lump, aspirate it. If it goes away, we're okay. That's the main thing to remember here. Fine needle aspiration of any cyst, send it to cytology. If the mass is gone and the mammogram is negative, we're done. If the mass persists or the mammogram is positive, then we need to excise it. But there is no good treatment for fibrocystic breast changes. No good treatment. Okay, fibroadenoma. A 25-year-old woman visits the gynecologist for routine annual exam. The exam reveals a palpable breast mass which has been present and stable for 2 years. What's the likelihood if a mass has been stable for 2 years of it being cancer? I mean, minimal. So this is most likely benign, and it is benign. It's the most common benign tumor in a young woman. The pathology report of the FNA was consistent with fibroadenoma. Now, this is not an aspiration, even though it calls it FNA. This is where you go in and out, and you take core biopsies like this. So you go in and out, in and out. And there's a classic histological finding. So if you would remember for the exam, a breast mass which is smooth and rubbery, non-tender, mobile. See, if it's a cancer, it wouldn't be smooth, it would be irregular. Instead of being mobile, it would be fixed. So this is the typical description of a fibroadenoma. We look at a sonogram. I'll show you what that looks like. It is a definitive evidence of either cystic or is it solid. Do a fine needle aspiration? Maybe. And the surgeon may elect to remove it, or they may decide to observe. And this is really a judgment call on their part. But this is not cancerous or precancerous. Here's ultrasound. An ultrasound is good for identifying cystic versus solid masses. I'm not an expert in breast ultrasound, but this is a simple cyst. You see the shadowing, which is behind here. This is concerning. Now, this is consistent with a fibroadenoma. So a sonogram can be very helpful. Mammography microcalcifications. A 45-year-old woman visits her gynecologist after having her yearly mammogram done. The mammogram reveals a cluster of microcalcifications. You can't feel microcalcifications. You can see them right here on the mammogram, but you can't feel them. See how dense this breast is over here? So the concern is that 15 to 20% can be early cancer, but you can't tell by looking. So you do a stereotactic core needle biopsy, outpatient radiology, and then you manage according to whatever the histology shows. So let's look at that. Stereotactic core needle biopsy. The patient is placed on this table. The breast comes down like this, and there is the machine, which will computer-driven, goes in and takes the biopsy. So here is the table. Here is the tumor. Laying on the table, here is the breast coming through. The technologist stabilizes the breast and the machine, makes an incision about the size of a pinhead, very small. The mammatome probe is placed in. Can you see it's got this opening? There is suction which is created. It sucks in the tissue, hopefully the area with the calcifications. A blade slides forward, traps the tissue in there, and you pull it out. Local anesthesia, yes. Incision, closed with a small bandage. That is what you do for microcalcifications. Okay, persistent breast mass. A 35-year-old woman has a persistent breast mass after FNA has been performed. The breast mass is confirmed by sonography. Now, we don't know if it's cystic. We don't know if it is solid, but it didn't go away. That is indications for open biopsy. And here you should know what are the criteria for open biopsy. Excisional biopsy, bloody cyst fluid, mass persists after aspiration, bloody nipple fluid, edema or erythema. You can manage according to what the histology shows. The open biopsy is done around the areola to make it cosmetically better. You can see the incision, which is right here. Okay, bloody nipple discharge. A 60-year-old woman comes to the gynecologist's office complaining of left breast bloody nipple discharge. Now, what is it? It's most probably an intraductal papilloma, which is benign. But you don't know that. You don't know that. So anytime you have bleeding, you really need to excise the duct and the papilloma and then look to see what it looks like under the microscope. Intraductal papilloma. All right, breast cancer. You've seen this picture many times. It's the most common cancer in women. 232,000 cases in the US a year. Okay, 65-year-old patient is found to have a solid 2-centimeter mass in the upper outer quadrant of the left breast, which is the most common location for a breast mass. It is in the upper outer quadrant. The biopsy is consistent with infiltrating ductal breast cancer. The most common breast cancer is infiltrating ductal, the most common. So this is in your book, page 261. Let's summarize what we've said. The most common breast malignancy, infiltrating ductal cancer. 80% of all breast cancers. Most are unilateral. They start as DCIS. What's DCIS? Ductal carcinoma in situ. It then invades the basement membrane. It can present as a stony hard mass, very fibrous. Normal duct. Intraductal hyperplasia. Atypical. Can you see the difference between the hyperplasia and the atypical? The nuclei are more prominent. Then it fills the entire duct. We call this DCIS, ductal carcinoma in situ, 11 times the increased risk of ipsilateral breast cancer. Ipsilateral is breast cancer in the same side. What is the next step if it gets worse? It breaks through. It breaks through and it becomes invasive, and now it can go into the lymphatics, and away it goes. So what we'd like to do is to get it here. not get this far. All right, infiltrating lobular carcinoma, second most common breast malignancy. 10% of all breast cancers. Actually, let me go back to here. With DCIS, often the recommendation is a prophylactic subcutaneous mastectomy. You take out the breast, you leave the skin, you leave the nipple, and then you put a prosthesis in. That's with the ductal. Now, with the infiltrating lobular, this is the second most common, but you can see it's not 80%, it's 10%. As with the ductal, it is often unilateral. It starts as lobular carcinoma in situ, which can invade the basement membranes, but better prognosis. So many times infiltrating, I should say, LCIS is managed conservatively. Watched serial mammograms, even serial MRIs, which are now being done. But that's a lobular carcinoma, better prognosis. Inflammatory, not good. Uncommon, rapid growth, early metastasis, blocks the skin lymphatics, redness, swelling, warmth on exam, and you have a peau d'orange. This is the orange peel appearance. And I'll show you what that looks like. Well, that's not really the best. Okay, here you can see more of the orange peel. This is bad actor. This is very virulent. I think this is probably, well, this is the orange peel. Anyway, peau d'orange, you think of inflammatory. Okay, Paget's disease, uncommon. Prognosis is better. It can present as a pruritic red scaly rash. Nipple can become inverted, and it can mimic a skin rash, eczema, or psoriasis. Does that look bad? No, that's not too bad. How about that one there? Well, oh, maybe a little more. How about this one here? So you can see it can be varied in its presentation, but typically it is a better prognosis. Now, breast cancer, most common female cancer, 1 in 12 lifetime risk. That's pretty high. 2/3 occur over ages. So if you have even normal lymph nodes, negative nodes, you should still give chemo and you should give radiation. It should be considered a systemic diagnosis. The relative risk is 100 times in women than in men. Men can get it as well, although it's much less of a problem. Same risk as lung cancer and heavy smoker. Now, heavy smokers can cut back on their lung cancer, but you ladies cannot cut back on being a woman. Not fair. Breast cancer is the most common cancer, but the most common cancer death in women is lung cancer. And that is largely preventable. Largely preventable. And cigarette smoking is clearly related to a lot of lung cancer. When you look at the risk of stroke in women smokers compared to women who haven't smoked, the more cigarettes, the higher the risk. Smoking steals 10 years from a woman's life. These are old advertisements. I mean, going back 50 years, but they're unbelievable. My throat is saved with Craven A. You can trust their smoothness and quality. And here's this woman saying, I really don't know if I should smoke, but my brother and my sweetheart smoke. And it gives me a lot of pleasure. Blow in her face and she'll follow you anywhere. I can't believe this. He says, mind if I smoke? And she says, care if I die? You know, this I think is just a crime. Advertising specifically to women. Smoking. It's a woman's thing. Hardly. Now, it's interesting. This is a marble of man. But where is the Marlboro Man today? This is David McLean. He died of lung cancer in 1995. This is Wayne McLaren. He died of lung cancer in 1992. This is Eric Lawson. He died of COPD 2014. Hey, the Marlboro Men are not around. That should say something. Okay, obviously I don't have a lot of good things to say about cigarette smoking. Breast cancer risk factors. This is looking at age. Clearly, age is a big issue. This is in your book, and it looks at BRCA1 or 2 gene, ductal lobular carcinoma in situ. Those are the biggest risks. Atypical hyperplasia, we talked about that, and so on. We already talked about Angelina Jolie. She had a double mastectomy because of BRCA gene. That is a big problem. This is kind of an interesting slide. It looks at related risk, hormone-related indicators of risk of breast cancer. The risk of breast cancer in the general population is this black line, 1. You can see with oral contraceptive pills, there's no increase in breast cancer. Now, estrogen alone, postmenopausally, no risk. Estrogen plus progestin, there is an increase. You see that? So it's not the estrogen, it's the progestin. Now, this is interesting. Women who don't breastfeed or women who have never had a pregnancy, they have a higher rate of breast cancer than women on estrogen plus progestin. History of breast cancer, first child after age 30 is 2.5 times. And this is increased breast density. That's amazing. So a lot of interesting findings with breast cancer. Now, why is there this difference between the US and Japan? I think tofu. I think it's diet related. I think there's good evidence for that. Okay, more breast cancer is found in the upper outer quadrant. Sentinel node biopsy. Okay, let's look at sentinel node. The idea here is if you have a breast cancer here, binding to a node over here, if you put some dye around the cancer and you look to see, is it taken up in the node? And if the node is negative, then maybe you can avoid having to do a lymph node dissection. So the sentinel node biopsy is you look for the node that has the dye because that's the one that could be a potential problem. This is a lymph node with breast cancer in it. Okay, node positive, early breast cancer. Healthy 55-year-old woman had a lumpectomy with negative margins, axillary node dissection for a 2.5 centimeter tumor, but she had 3 positive nodes. As soon as you have nodes, that's stage 3. The tumor was positive for both estrogen and progesterone receptors. If there's any good news, that's the good news. What do we do? Okay, lumpectomy, early stage, unilateral, over 4 centimeters or less than 4 centimeters, do a lumpectomy. It took many years for the general surgeons to realize you don't need to do a radical mastectomy. A lumpectomy with radiation and chemo is just as good. Are there patients who need a mastectomy? Yes. You can have a simple subcutaneous mastectomy, leaving the nipples and the skin, DCIS, LCIS. We talked about that. Modified radical mastectomy if the tumor is over 4 centimeters in size. Now, this does not take off the pectoralis muscles, so it leaves the chest wall muscles. The radical mastectomy is what takes off the chest wall muscles. That is seldom done today. Radiation, always after lumpectomy. Remember I said it needs to be considered a systemic disease on diagnosis. If she is estrogen or progesterone receptor positive, then you could use an anti-estrogen or an anti-progestin, and that could then help in those patients. Of course, they're going to get a lot of hot flashes. Chemotherapy, if the nodes are positive or the size is over 1 centimeter. So let's say we have a 2 centimeter size mass. What should we do? We're going to do a lumpectomy because it's less than 4 centimeters. It's unilateral. We're always going to give radiation, and we're going to give chemotherapy. So most early cancers will be lumpectomy, hormone therapy, and radiation therapy. See, this is your modified radical where you go up and take the lymph nodes, but you also take out the superficial chest muscles. The radical mastectomy goes all the way down to the ribs. Now, this is where you do simple mastectomy. You've only taken the breast off, but I want you to look at how good the reconstruction can be. What do you think? I think that is really pretty good. Lymphedema, always a problem when you do axillary node dissection. This we don't see now. Okay, breast cancer. Haven't done a whole lot to decrease breast cancer, fortunately. Colorectal cancer, we've done pretty good. Stool guaiac and colonoscopy. Cervix, we've done pretty good because of pap smears. Ovarian cancer, I think probably is increasing because lifespan is increasing, but we haven't done a very good job with that. But this is a tragic one. Lung cancer in women. Due to smoking, most of the time. Now, fortunately, when we look at lung cancer incidence, and this is women, you can see that women, it has increased until about 2004 or 5, and now it looks like it's on its way down. And smoking is also down. So that, I think, is good. Okay, Amanda, let's go on to the Q&A. And I'm going to show you my favorite slide. And then I think we'll be done. I'm trying to, can't get it. I don't want to go all the way through. How come I can't see the side bar here? Okay, I'll just have to go all the way through. Okay, this is my favorite slide. Now there is sound, but you can't hear it, unfortunately. But here we go. Okay, ladies and gentlemen, it's been my pleasure. I hope you do well, and let me know how you do. And have a good night. Thank you very much. Okay, thank you very much.